we have a Manoj.
Yeah.
We have a MMC point and Nitin Bhagli is here as a MMC observer. You have to introduce him also. Okay.
Good morning, everyone. We welcome you all to Ortho TV Online in association with Maharashtra Orthopaedic Association. To introduce today's topic and the speakers, I hand over to our President, Dr. Gadegone.
Give brief introduction, Manoj, first.
Yeah. So, very good morning to all of you. So, I welcome you all for this MOA webinar. It's basically an MOA masterclass of Veteran Surgeons Forum. As we all know that we spend our most of the time in operation theatre, so very essential to have all the perspectives and different aspects of operation theatre so as to make it more efficient. We have devised this OT is my temple as a concept. It will be in 3 sessions. This will be the first session today with many eminent Galaxy stalwart faculties from across Maharashtra. It was basically conceptualized by Dr. Wasudeo Gadegone, sir, our MOA president. Convener and secretary of MOA, Dr. N.J. Karne, will be there for this today's symposium. We do have a guest state chapter association from Chhattisgarh, Dr. Alok Chandra Agarwal, who is the HOD at AIMS Raipur, and this will be he will be moderating along with this MOA team for this today's webinar. Today we will moderator for today's session is none other than Dr. Vikas Agashe sir, another very expert and senior most faculty from Mumbai, and with him I will be coordinating this today's session. Dr. Nitin Bhagli is also there. We do have achieved MMC credit points for this today's webinar. I also welcome him. We do have all expert faculties who doesn't need any introduction. Dr. Sushrut Babhulkar sir from Nagpur, Dr. V.N.Deshpande sir from Ahmadnagar, Dr. Ajit Phadake from Yeotmal, Dr. R.M.Chandak sir from Nagpur, Mrs. Netra Vaidya from Mumbai, Dr.Sandeep Patwardhan from Pune, Dr. Vikas Agashe sir, and I will be also presenting individual topics towards the end of this today's symposium. And Ortho TV has already will be supporting.
Let me interrupt you. Dr. Aditya Menon, consultant from Hinduja, also will be discussing with me.
Yeah. Dr.G.S.Kulkarni also.
And
Dr.G.S.Kulkarni from Meeraj.
Last but not
yeah. So for further giving a brief outline for why this concept, I will hand it over to Dr. Wasudeo Gadegone sir.
So good morning everybody. My secretary Dr. Karne sir will give a brief the motto of Maharashtra Orthopaedic Association bringing out this concept of OT is a temple. Please, Karne sir.
Good morning everybody, and immense thank our honorable president Dr. Gadegone sir. Well, the Maharashtra Orthopaedic Association has geared up a lot after in this new year, and we have got a lot of webinars here on behalf of all the panelists and the experts all over Maharashtra. We have decided to go to every nook and corner of the Maharashtra, and our central focus is on the peripheral orthopedic surgeon. We see many webinars where the highly expert things are being told at the top, but then how much it is useful for a peripheral orthopedic surgeon next day morning in his OPD or OT, that is very important. And so our honorable president Dr. Wasudeo Gadegone has formulated different types of webinars, and one of them is this Veteran Surgeons Forum. There are 2 forums. One is Young Surgeon Forum, where we give the chances to all the budding and recently passed out orthopedic surgeons who are very much active and want to present themselves. At the same time, this Veteran Surgeon Forum is designed to give the highly experienced input to the peripheral practicing surgeons. And one of the very important things which are generally neglected in most of the webinar is the operation theatre, especially for those who are having their nursing homes in the periphery of the Maharashtra. And I really congratulate Dr. Wasudeo Gadegone sir that he has this idea in the mind, and there will be 4 webinars of this kind. And not only this, MOA is going to publish a book on this OT is my temple, which will constitute most of all these things. And I thank MOEC as well as Dr. Gadegone sir for having this particular concept, and which will be there with in every operation theatre all over Maharashtra. So I thank Professor Gadegone and our for this, and I welcome all the faculties, expert faculties all across the Maharashtra and the stalwarts, as well as my good friend Dr. Bhagli, who is here as a MMC observer, and I wish best for this webinar. Thank you very much.
So, without wasting time, further proceeding, I will hand over to mic to Manoj Pahukar and Vikas Agashe to have further proceedings of this webinar. Continue.
Yeah. I think we should start with the first topic for this today's OT is my webinar. May I request Dr. Sushrut Babhulkar sir to start sharing his screen, and his topic is about introduction to operation theatre and history.
Good morning, everyone.
I request all of them to unmute their picture. Actually, video you can see this, but unmute your PC so that
Mute,
clear.
Mute your audio.
Mute. Okay.
Good morning, everyone. At the outset, let me thank Maharashtra Orthopaedic Association and dear friend Dr. Gadegone to have this idea of operation theatre. How to design what we should do when we try to build our operation theatre or rebuild our operation theatre. My task is to brief you on some historical aspect, how we have come to modern design concept of operation theatre to begin with. Why history? Because if we fail to really look at the history, we are condemned to repeat all the mistakes that have happened in a few generations back. So what is operation theatre or operating room or operation suite? It's a facility where we spend most of our creative time as an orthopedic surgeon doing surgeries. And it is so important because that's what is going to yield a good outcome for our patients. So if we really look at the historical aspect of operation theatres, they were basically amphitheatres wherein some procedure was performed in the central area and people would watch as an amphitheater what was happening in the well. The operating rooms did not exist till 8000 before Christ, when Egyptians recorded trephination. So what is trephination? Is one of the oldest surgeries when they used to grind a hole in the skull. And it is known because those remnants are seen, which are almost 12,000 years old. But if you really see when was a good, sensible operation theatre was designed, it's not seen even when the law code of Hammurabi was established, which is 1700 before Christ. But when we talk of Egyptians seem to have developed some instruments, surgical instruments way back in Egypt. India, when we look at India, when did we start looking at operation theatre? So to cut your nose, to spite your face is familiar to all of us. We know it from Shurpanakha, Ramayana days. So nose cutting, earlobe was popular surgeries those times in India. And I'm namesake of Sushruta. He is now considered as father of surgery, but he is the one who kind of developed an operating room, which was a separate entity, even today seen on the banks of Ganges in Banaras. They have recently opened it 2 years back, which is Sushruta's ashram. Sushruta, who was son of Vishwamitra, who designed some very delicate, even today, some modification of it is used in plastic surgery. So those were the days, but operating room concept was there in Sushruta time. I'm talking of almost 400 BC to 800 AD, that time period. So that was the time period when he was there and India had concept of operating room. China, Hua Tu was the first one who used anesthesia by using wine and cannabis. When we move to Greece, Greeks were the first, maybe intelligent, maybe very formal surgical training program was established in Greece. Greek surgeons were trained in semi-formal schools like ashramas, which were called as Asclepia. So Greeks were way ahead in terms of their thinking as far as Europe is concerned. When we move on to Rome, Romans were the first ones again who established a operating tent. Now, this tent concept, we will come back to it again later, but Romans thought that there has to be a shelter and there has to be a dedicated space, which was the operating tents. In Islam, the first surgical suites were built. So Abu Bakr al-Razi was the first person to introduce alcohol as anesthetic agent along with wine. But when we move to Middle Ages, we surgeons were called as barber surgeons. And we mostly performed surgeries with caravans. In battlefields, they were very active. When we moved to Napoleon era war, Dominic Sean Larry was the army surgeon of Napoleon. He reintroduced Roman-style hospital tents, this time right on the battlefield. And these hospital tents, we will again look at it. When modern operating rooms came in vogue in Boston, they applied the similar principle of having tents. And then in today's world, it has been conceptualized again to have laminar airflow. So we have walked from Roman era to Napoleon era to Boston, where at St. Thomas's Hospital, they started using tent-like structures, to today's modern laminar airflow. American Civil War saw a huge replica of multiples of these kind of tents. So that's one of the picture which I could get during American Civil War. Germany, France, Austria, England, Americas followed a similar pattern. But the most important is the last line. In 1822 at St. Thomas's Hospital, Operation Theatre, and in 1824 in Boston, the Ether Dome was built. So those people who are interested in architecture of operating rooms, this is extremely important to know how the whole design concept evolved, so that you build your own personalized operation theater based on evolution of these designs. World Wars have always given us great opportunity to develop and modernize ourselves. So gowns, gloves, masks, washing of hands, use of antiseptics came into vogue during World War I, World War II, and the Korean War. We developed more and better design concepts, and these are various operation theaters which started right from a modern operation theater way back in 1952 in Israel to what we have as operation theater suites today. So in next few talks by various senior and fellow colleagues, what we are going to look at is how to develop your mega theater if you want to have multiple theaters in the same complex, which can be, for example, I have 3 theaters. One is dedicated to open fractures, debridement, those kind of things. No clean surgery goes there. So that is one theater, multiple barriers after that, 3 to 4. Then 2 theaters, a bigger size theater to accommodate my image intensifier, to accommodate all the trauma, operational theater, table, accessories. So you can have multiple theaters in one complex, or we are also going to talk about small size setup wherein we can have in a small size but very effective operation theater. We are also going to talk in next few lectures how to design a door. How the door should be flip open, inside out, or a sliding door. How should the passages be? If there are 2 or 3 operating rooms in your setup, How should one design the passages? We are going to look at that. How you should have inside operation theater storage spaces. So storage space can be made up of steel cabinet. They should be flushed to the wall. How we should design them, how and how much to keep accessible on the anesthesia trolley. We will look at that. So storage space design is very critical and we'll talk about it. How should we design our scrub area? Does it have to be as fancy as is shown here? Does it have to be only a basin? Is it, should it be a hand operated thing? Should it be a pedal operated thing? What gloves should we use? Should main primary surgeon should be using a different glove, one glove, two glove, inside bigger size, outside bigger size? We'll talk about gowns. We will talk about caps and masks. What should be used? We will go into details of this. And of course, fancier operation theaters, wherein you can have a C-arm or a O image intensifier, which will give you an ability to screen or navigate your trauma patient right there, to screen or navigate immediately after joint replacement. Is it possible? Is it feasible? Economically, commercially, we will talk about that. So in few next talks, few next sessions, we will go through all this. We will also go through an area which is immediately after operation theater, which is the recovery area. What should we facilitate that with? Should we have monitors? Should we have oxygen? Should we have suction? We will talk about how to maintain your accessories very easily accessible to you, to your next in line. How many people, how many personnel should be kept in operation theater? Again, going back to the figure on the right, oxygen, suction, should it be centralized? If it has to be centralized, how should we go about it? What kind of autoclave, vertical, horizontal? Which one? Should we buy ETO in my setup? We'll talk about that. And lastly, we must create an orchestra so that when you are inside theater performing what you need to do best, you create a terrific ergonomics of operation theater, so that once you start and put a knife on the patient, everything flows like a music till you take the last stitch. So friends, stay tuned and listen to next few great talks which my fellow colleagues are going to deliver. Thank you very much.
Sushrut,
thank you very much, Sushrut.
Excellent
really
presentation.
Played like Tendulkar.
Thank you, sir. I don't think I will have any questions, so we can move on to the next talk straight away.
Yeah. So we'll go to Dr. Deshpande, and then maybe we can combine these two talks and have questions because they are related. So from very ancient operation theaters to how to design operation theaters for a small nursing home is what Dr. V.N.Deshpande from Ahmadnagar is going to discuss. May I request Dr. Deshpande to share his screen and start the talk?
Yeah. Is my screen visible to all?
Yes.
Yes. Fine. So without wasting time, we begin here. I'm Dr. V.N.Deshpande. To introduce myself, I work in Ahmadnagar. This is my hospital. And I'm thankful to the MOA, Dr. Gadegone.
Sir,
Dr.
full
Karne.
screen. Full screen, kara, full screen.
Okay, fine. Is it okay, fine now?
Yes, yes.
Yes. Yeah. I'm thankful to MOA, Dr. Gadegone, Dr. Karne, MOA EC, all past presidents and friends. I'm also thankful to these referring articles to which I referred. One is from Anesthesia Journal and other is from India Medica. This has helped me to pen down or put my thoughts ahead, which also include NABH guidelines. I do respect my own mistakes from which I learned and my observations as well when I visit other hospitals and operation theaters. Operation theater is heart of every surgeon. Our President, sir, has rightly said, OT is my temple, and we all worship and respect the sanctity and holiness of our operation theatre. There are many similarities between the temple and OT. Due to paucity of time and to make my my presentation very crisp, I won't be going into details. The theme which I am using as a background itself uses the similarity. The one above is a temple and the one down is the operation theatre. I also thank at this juncture to Sushrut for presenting a bird's eye view how the theatre and this theatre is my temple workshops and the master class would be going in. The OT should be as comfortable as possible to everybody. The establishment of working of operation theatre needs a specialized planning and execution and is not a simple civil engineering work. It's a civil, mechanical, electrical, electronic and biomedical. The main objective of planning should be to promote high standards of asepsis because hospital acquired infections and the surgical site infections kill lot many patients across the globe. We have to ensure maximum standards of safety. We optimize the utilization of operation theatre as a room as well as the staff's time. We optimize the working conditions, as Sushrut rightly said, the ergonomics of the operation theatre. Patient and staff comfort, as far as thermal conditions are concerned, make most important point about the air conditioning in countries like India. Acoustics and lighting requirements are also very important. The theatre should allow flexibility, facilitate coordinated services, and minimize the maintenance. As a hospital or nursing home owner, I would prefer my theatre would not cost me much on maintenance. At the same time, it would generate lot of revenue. We should plan rather our practice. Hospital is a part of it, and the theatre, of course, is a part of it. But we have to consider in a small town or a middle class town like Ahmadnagar and the block places, FSI changes from each and every city. Government rules about hospital buildings which keep on changing every now and then. Road width, the fire safety, which has to consider the height of the building, because if your corporation does not have a big bump or the big fire vehicle and the ladder which they have to have is not there, we get restrictions on the height of the buildings, surrounding space, the plot size, the commercial and non-agricultural permissions, residential zones, nuisance from the colony or the area where the hospital is situated from the public as well. We have to plan a spacious operation theatre because it's a war room for we all. We have to face any situation in any given moment. We have to also plan a good surgeon's room, good corridors, and adequate spaces for everything. So for any operation theatre, an area of about 200 to 225 square meter, that is 2000 to 2500 square feet, may be adequate, but it has to be designed according to the need of the practice, and we have to keep a room or a space for future developments. If you look at the circulation in operation theatre, the point down, can I see my pointer, is the aseptic zone where we all operate. From there, we come into the clean zone and then into a protective zone. And for outside, there is a space, or there has to be a space for shoe rack, relatives waiting, and everything. The entry for a surgeon and patient are different. The OT staff or surgeons, they enter into a changing room, change into the scrub suits, wear cap and mask, go to the scrub area, and then go to the operating room. Patient one may enter, once he enters the OT, goes to the common corridor, enters the passage, goes to the clean zone, and then into the aseptic zone or the operating room. But while going out, he has to go to the recovery room. If you look at the pressure gradients, the OT has to be positive pressure so that the outside air doesn't enter and the air flows from inside to out. The bacteriological count as well has to be low into the operating room, and it increasingly goes out as we enter, as we go outside. Has it hung up? 1 second. Yeah. If we look at the location of the operation theater, the location we have to is a very critically important, it's of paramount importance. The advantage of natural light, if possible, it should be easily accessible, yet it should have a less traffic. There should be safety norms which we have to follow, as well as we have to consider some social events wherein we need to have some safety exit as well. The location must facilitate for easy movement of surgical equipments and the biomedical equipments. Which flavor to place the OT? In my entire career, I have had OTs right from basement to the top floor. I mean, I know the advantages and disadvantages of each and every floor. I'll try to sum up. How many floors you have in operation theater, that has to be considered first. The basement, there is a drainage problem. There is a natural light problem. But you do have an advantage of saving electricity bill consumption on air conditioning. First and other floors, like first floor and other floors, there is a movement of relatives from other floors. It may be a matter of nuisance to you. More movements cause need more frequency of cleaning. The more footfall calls for more, more problems. Top floor AC requirements are more. Ground floor, it's a commercial space which you would like to share or spare for shops and casualty and reception. So for saving energy, you can shut down one of the floors. In a small nursing home I'm talking. So you can shut down one of the floors which is not in use, and especially that is a theater floor which may not be in use 50% of the time as compared to your wards and the rooms. If you keep ward or rooms on the top floor, the frequency of traffic increases, as I mentioned. Lift is definitely of a very important convenience. Earlier, few nursing homes may not have lifts, did not have lifts as well. Distance from oxygen and gas pipeline or from cylinder bank has to be as less as possible for leakage, the safety measures, and the dead space. Where are you going to AHU, air handling unit, has to be also thought of. According to me and my experience, the top floor with an open tin shed on the top becomes an ideal place for an operation theater in a small nursing home setup. We can utilize that place for drying up of cloth unless you are outsourcing the laundry section. The power generation on the shade or on the tin can also be taken care of from the solar energy. The laundry and the instruments, where are you going to wash? That is also an important point. And the water drainage, it has to be connected to the sewage treatment plants. The disposal and stock of biomedical waste till the van comes, because every hospital practically or every city practically has a biomedical system which is a centralized, and a van collects the biomedical waste from the hospital to the biomedical disposal center. The CSSD, the air outlets of ETO, if you are planning to buy an ETO, earthing of the electrical equipments is an important point. Zone-wise distribution of the operating area has to be considered to avoid crisscross movements of men and machines. Adequate appropriate spaces, as I already told you. Provision for ventilation, temperature control, keeping in mind the need of laminar flow, or if you are going to go for laminar flow right in the beginning of a setting up of a nursing home. Provision, operation table, the operation table per OT has to be there. We have to plan for X-ray illuminators, scrub areas. The scrub area may be for 2 or 3 persons. As Sushrut rightly said, a separate scrub station for a surgeon or a scrub basin. Whether we want to go for an elbow operated COX or a sensor operated or a put operated taps. No, I suggest no instrument washing in the scrub basin. We have to have a separate space for cleaning up of instruments and evacuating of a suction machine and the materials, which I'll show in a later slides what arrangement I have made in my own hospital. There has to be a preparation zone in the clean zone, corridors of not less than 3 meter width, and for easy movement of men, oxygen suction for all OTs and the places wherever patients are to be held up. Provision for adequate continuous water supply is must. If you are going to use bore water, use water softeners and do not waste time in adding it because it chokes up your caulks and drainage systems. Then drainage systems are to be wide. They have to be non-blocking. The reception outside the OT is also a very important asset because that keeps relatives informed about what's going on inside. Provision for shadowless lamps on ceilings, fire extinguishers, provisions for expansion of OT complex. Pendant services. There have to have two ceiling pendants, one for anesthesia and one for the surgeon. And the pendants have to have be mobile in 355 or 360 degrees practically. They have to have lateral movements because that reduces the space whenever you have to have a OT trolley, C-arm, and many other gadgets which we need to. The scavenging system, it's exhausting out of the anesthesia gases. This scavenging system is also very important. It's active and passive. Most of the theaters in small hospital may not have scavenging system, but it reduces your tiredness, it increases your efficiency. There has to have a communication system, telephones, intercoms, and code signals activated. But I will suggest a bail system because in a small hospital of a 25 or 30 beds, wherein manpower is also less, picking up a phone may also be difficult for the staff sometimes. And we have to have an arrangement for data management, internet connection, and a pharmacy because during surgery you may require some suture material or some drug which may not be in stock if you have not checked it properly beforehand. The construction material selected for operation theater has to be needing minimum maintenance and minimum cleaning cost. It is better to have two OTs or multiple OTs as per requirement of the particular hospital or a nursing home. As far as 25 bedded to 35 bed, 30 bedded hospitals are concerned, two OTs are good enough. One for compound infected trauma and so-called dirty cases, and one for the joint replacement, spine and clean trauma or elective surgical procedures. Consider a factor if your spouse is a doctor and she needs to use theater as well. General or considerations, what should be the room size? The room size main operation theater should be 400 to 450 square feet. Height of the operation theater should be at least 12 feet below the false ceiling to have good plenum, good HVAC ducting, and OT light fittings. The OT room should be preferably free of beams, free of columns. The beam in OT, if at all, should be avoided in the center and it can be taken little offside. If the beam is there, it should be out of the center. There should be no any projection or any shaft or any column. The wall should be double brick. That is to consider the sound system. I mean, outside sound or inside sound should not go out. Radiation hazards have to be considered. No sewage or drainage pipe should pass through the theater. There should be no fire sprinklers into the operation theater. These days, the fire safety measures have become compulsory for every hospital. If you are going to convert your theater into a robotic surgery, you may have to consider little more space. And the door of a OT, what type of door it should be? Each OT should have one for patient entry and another for doctor's entry. If you are going to have two entries, the first entry should be in the center and the second entry should be at least 3 to 4 feet away from the corner to install the returning air of the laminar flow. Door should be automatic and hermetically. That means airtight sealed. Sliding doors are preferred, and double leaf doors are also preferred, because the swing doors, they generate a pressure, and the positive pressure inside the OT is disturbed. Each OT should preferably have a window to reduce the claustrophobia of the surgeon. These days, with laminar flows, there are windows which are nicely designed and which create a virtual window-like effect. The OT window should be flush from inside, and it should have a double glass, and which should be a toughened glass, and it should be screened with a sun blinding films. The walls of the operation theater can be glass walls, puffed or insulated walls, or conventional material. The ceiling to wall and wall to floor, there should be no sharp corners. And sorry? There should be no corners, no offsets. The tiles can break and epoxy paint can chip off. Collision corners to be covered with steel or aluminum corners, aluminum plates, because if the stretcher hits against the wall, it creates rough surface, which is bad for cleaning and which creates a dust lodging area into the operation theater. The colors should provide a seamless wall, no joints, and it should be gloss to semi-gloss. Even if it's a matte finish, it should not allow the dust to lodge in, and it should make the cleaning of the walls very easy. Coating of the wall should withstand continuous cleaning, washing with detergents and the disinfectants, and it should not damage the paints. Epoxy and polyurethane coats are used because they do withstand with washing with hot water and water cleaning with detergents and disinfectants. The coating should be non-alloying. Of course, that does not hamper the cleanliness or the germ generation into the operation theater or fungus generation. But whatever color we choose, that should be maintained for a longer period. The surface.
Deshpande sir, yeah. Can I interrupt?
Sorry, please go ahead, sir.
Yeah, can we just briefly summarize? I think.
Is the time running up?
Yes, sir.
The surface we all prefer impervious, strong, and if the instrument falls down, that should not damage. The epoxy coating, rubber. The ideal flooring is homogeneous sheet vinyl or homogeneous sheet rubber or flooring. Epoxy flooring is a family of basic resins, and that is nowadays I think most of the theaters have it, but we should go in for vinyl floorings. Ceiling, we should have enough heights, and roof mounted lights, plenum of laminar flow has to be adequately fitted. I'll show you how to carry the linen and instruments from the operation theater, because the dirty zone, if it is next to the clean zone, I mean sterile zone, it will create nuisance. So in my hospital, I use these two trolleys. The one which is labeled green is to carry the sterile instruments, and the one which is labeled red is to carry the unsterile instruments and linen outside the theater. For evacuation of the suction machine, we have created one such system wherein we drop the suction and everything which is particulate and which is connected to the sewage treatment plant in our hospital. We have dedicated a space of about 10 by 10 size for this special purpose. Surgeon's room design has to be specially considered because it is his own space. It's his relaxation room. It's his library, and it has to have a good internet connection. This is his confidential room as well. So, I'll stop my video. There are usual areas of lacunae. Can you hear me?
Yes, sir. Yeah, please.
Yeah, I'll stop my video now because probably the internet connection is not very stable.
We are able to listen you properly, sir. Yeah, please.
Right, fine. Most of the times there is no reception area, no separate room for surgeons, anesthesiologists, junior doctors because of the space constraints, not enough number of changing rooms for a different class of people. inappropriate sizes of rooms, doors, etc. is a concern in hospitals which have been built in older times. The waiting area is not equipped with basic amenities like washrooms, coffee vending or tea vending machines. I suppose, yeah. The authorities for standardization of the operation theatres are NABH, Corporation, Civil Hospital. The hospital can be accredited by JACO as well, JCI. In conclusion, give maximum importance to planning of operation theatre complex with limitations of finance and space. Effort should be made to confirm the standards laid down by the local authorities. However, new OTs and hospitals that are being established, the rules regulations keep on changing. Therefore, keep some space for future developments. And I thank everybody for patient listening. I thank MOA and its Managing Governing Council for giving me an opportunity. Thank you very much.
Thank you very much, Dr. Deshpande, for a fantastic talk. I suggest that all of you should visit his talk again, because he has dealt this in such a great detail that it would be very, very useful for everyone to plan or modify the operation theatre. Thanks a lot, Deshpande sir.
Thank you, sir.
Shall we go to the next talk now? May I request Dr. Ajit Phadake, who would be discussing environment, temperature, laminar flow. And I request all the faculty members to stick to time. At 12 minutes, I will have an alarm, and at the most 1 or 2 minutes we can have, but then you would lose time for discussion. So since we have limited time, I request everybody to finish in 12 minutes so that we can have 2 or 3 minutes for discussion. Thank you, friends. Dr. Phadake, please go ahead.
Thank you, MOA, for giving me this opportunity. I'll be talking about the environment, temperature, oxygen, and laminar air flow, which is part of the operation theatre. We have already seen this in Sushrut's talk. Of the aims of the safe operation theatre, ergonomically sound and zero infection rate, these two aims are dependent on the environment. We have two different types of operation theatre systems. One is the conventional operation theatre and the modern modular operation theatre system. The basic difference in the two is that a modular system is really required when there are multiple operation theatres, and each OT is a unit by itself, and the controls of the humidity and temperature are independent in each operation theatre, whereas in an operation theatre suite or the conventional operation theatre, all the controls are centrally located, so you cannot change the humidity or temperature in each individual operation theatre. The rest of that you can go through. As Dr. Deshpande has already said, the location, it should be accessible or attached to the main hospital or within the main hospital, but there should be less traffic. You should not have people moving around. It should be well ventilated with clean air and sufficient light, and it should have space for all the components that are required for an operation theatre. There is the operating room, work and rest area for doctors, the changing room, nursing station, autoclave area, and disposal area. The zones already have been covered. I will not go through that. The operation theatre should have a size of ideally 500 to 600 square feet, so that you can comfortably move around the operation table without having to change the position of the operation table for each surgery. Sliding doors are preferred, and the floor should be slip resistant. We have already seen about the walls and ceiling mounted lights. The basic thing is there should be no ledges inside the operation theatre. All the ledges are places where dust can accumulate, so you have to avoid having any ledge inside the operation theatre. This is a flow diagram for an operation theatre. The patient enters in, and if it's possible, you should have a separate anesthesia room where the patient is induced and then taken to the main operation theater. From there, he goes to the recovery room and then outside. Now we come to the temperature of the operation theater. I'll go a bit in detail about this because this has not been covered. What is the aim of having a temperature control in the operation theater? Is that you have to prevent hypothermia of the patient, and also you have to prevent infection. It should be comfortable for the staff to work in, and 22 to 24 degrees centigrade with a humidity of 50 to 60% is the ideal temperature for an operation theater. Now, if you are operating on an infant or a neonate, say for a CTEV, the temperature should be slightly higher because they are more prone to hypothermia. Whereas if you are doing a joint replacement, it is considered that 20 degrees centigrade is the ideal temperature for doing a joint replacement. But in this case, if the patient is going to get hypothermia, it is better to use body warmers. Hypothermia of the patient is not good. It is dangerous. It causes a lot of electrolyte imbalance, and also it has been shown that infections are higher if the patient has hypothermia during surgery. The pressure inside an operation theater should be higher than outside, so that the air from the OT always flows outside through the cracks and not the reverse. Now, how do you control the temperature and humidity and pressure? Now, this is done by the air conditioning and ventilation systems or the air handling unit. Now, the controls of this air temperature and humidity should be inside the operation theater, so that in the modular theater, each OT can adjust its own temperature and humidity. 400 air changes per hour are what is ideally described for operation theater. And I'm still not considering about laminar airflow, which forms a separate part of my talk. This is briefly how the air circulates. The OT light has to have a high intensity illumination on the operation field, of course. And if you see carefully, these OT lights have different heads and not one dome as previously was the fashion. This is to prevent obstruction to the laminar airflow. The rest of the OT has daylight tubes, which with an emission temperature of 4000 to 5000 K and illumination of 325 lumens per meter square. The recovery room should be slightly darker for comfort of the patient. If available, daylight should be there in the operation theater, but it's not mandatory. OT is the place where outside light is not necessary. The oxygen and anesthetic gases, you might have two different fashions in this. If you have a small OT in a small setup, then you might use compressed air or compressed gas cylinders. These are usually used as emergency or standby on a workstation or boil apparatus in a bigger OT setup. In a bigger OT setup where a hospital is big, piped gas from a central supply is usually available and it is color coded. We'll come to the color coding. The oxygen concentrators may be used in the recovery room, but they are not useful for anesthesia machines. Medical oxygen is defined as 94% pure oxygen, the rest being a mixture of nitrogen and helium. This is the ISO color code which we follow in India. The important thing is white is for oxygen, yellow is for vacuum, and blue is for nitrous oxide. For larger hospitals, there are two options. One is an array of gas cylinders where you have two different sets of gas cylinders. When one is supplying oxygen, the other is on standby. When this runs out, the standby takes over by automatic switchover and you have to change the cylinders. The bigger theaters now and bigger hospitals now have a liquid oxygen container which is filled directly by with liquid oxygen and supplies oxygen to the whole of the hospital. The laminar airflow forms an important part of my talk, and I thank Dr. Vikas Agashe who has provided me with valuable inputs on this. Why is it so important? Because there is a lot of controversy in this. Many people do not know about it. Now, this staphylococcus is obviously the greatest enemy of orthopedic surgeons. Nobody wants infections, and we all aim at zero infection rate. And Sir George Charlie also harbored the wish to reduce infection rate, and 53 years ago he introduced laminar airflow in a clean air enclosure, and his infection rate dropped from 10% to 1%. However, he believed that this would negate the need for prophylactic antibiotics, but it's not true. Prophylactic antibiotics have been shown to be useful. Now, what is a laminar airflow? Laminar airflow is a low velocity flow of air, which is smooth like a viscous laminar airflow of like a viscous liquid through a tube or a pipe. So you can see sheets of air moving parallel to each other without mixing up. Whereas a turbulent airflow has got eddy currents and with a lot of lateral mixing. And it's a rough airflow. This is done by the air conditioning or AHU, air handling unit, and you get a laminar airflow on the operating area. The whole of the operating area and the operating team should be covered by the laminar airflow. There should be as few obstructions to this flow as possible. The laminar airflow has 3 filters: a micro pre-filter, a fabric filter, and a HEPA filter. Now, HEPA filter is important because it filters 99.97% of particles that have a size of 0.3 micrometers. So, except for the viruses, everything else is kept out. How do you get infection in surgical wounds? Because there are bacterial clumps on the dust and skin of the OT personnel and the lint which comes from the gowns that we use. Now, these work as carriers or flying saucers for the bacteria. These bacteria are deposited on the wound and they cause contamination of the wound and infection. The more people there are, the more skin scales and more colony forming units. So to reduce infection rate, we have to reduce the contamination. You have to reduce the colony forming units by avoiding turbulent air currents, and we have to drive air away from the operating field. So you need a laminar airflow directly on the operation theatre field. Now, this remains laminar as long as there are no thermal obstructions or disturbances. So, lams are an important obstruction to that. The laminar airflow has a very high running cost, which you have to consider when you are running a hospital. For a big operation theatre, it might be as much as 6,000 rupees per day, and for a small OT, it will be 3,000 rupees per day. Now, what is the controversy in this? Logic says that laminar airflow will reduce the contamination and will reduce infection. So, a large number of studies have been carried out till date to prove that laminar airflow is useful. But is it really useful? So, the first study from New Zealand showed that actually the infection rate was more when laminar airflow was used than when it was not used in a conventional theatre. The boss of infection, that is Javed Parvezi, had a consensus meeting on periprosthetic joint infection, and after 2 days of discussion, they concluded that arthroplasty may be performed in operation theatre without laminar airflow. Of course, the OT has to be clean, but not laminar airflow is not mandatory. So here we have the controversy. Operating room ventilation with laminar airflow has no protective effect on surgical site infection. And in Germany also they carried out a similar study, and they found that laminar airflow has no benefit at all, and it was actually shown to have a higher risk of SSI after hip procedures. Now nobody knows really why this has happened, why laminar airflow causes more infection. Now that is basically probably because the rate of infection is not only dependent on the airflow, but it is also dependent on the skin of the patient, septic focus, the surgical team, and mops and instruments. So you have multifactorial origin of infection.
Dr. Phadake, you have.
Yes. I'm concluding now. Okay. So, in spite of all these studies, the Dutch work group strongly recommended use of laminar airflow in arthroplasty. It was based on old data and non-randomized studies. So, though there is no documented proof that laminar airflow is useful, why does everybody insist on having laminar airflow in their operation theater? The argument is that everybody has it. So, if I don't install a laminar airflow, I am the odd man out. NABH recommends laminar airflow, so you have to install if you want a NABH certification. Absence of laminar airflow might be used against you in the court of law. The important thing is that you might as well have a laminar airflow, but you should not have a false sense of security. You should spend more time and money on correct prophylactic antibiotics, reducing traffic in the OT, careful preparing and cleaning of the OT infection site, covering of exposed hair and skin, and good surgical techniques. These are probably more important to prevent infection than the laminar airflow. So what is the carry home message is, if you don't have a laminar airflow, don't bother too much. You follow all the other precautions. But if you want, you can install the laminar airflow, but pay more attention to the other factors of preventing infection. Thank you very much. I have put up a big issue where I'm sure many people are going to fight with me, but I am prepared with all the documents to defend myself. Thank you very much.
Thanks a lot, Dr. Phadake. We'll take two questions regarding Dr. Phadake's talk.
Sir, I have a question to
Yes.
Dr. Ajit Phadake. What about the fungus
Ajit,
which is grown?
stop sharing first.
Yes.
Stop sharing.
Yeah.
Okay.
Ajit,
Yeah.
have you any study or have you come across any study how to prevent the fungus growth in the ducts of the laminar flow?
No, really, but that is a good question. I'll have to go again back to the literature to find out how to prevent fungus. It basically you have to avoid humidity to prevent.
Obviously, yes.
Flow.
I did discuss this problem with the laminar flow installers. According to him, you have to clean up the laminar flow system itself, the ducting system as well, every year or so.
Right.
Yeah. I mean, I'm also not sure. I raised this question only to put your inputs
Yes.
and get some inputs from you as well.
Actually, we get it serviced every 6 months.
Yes.
Okay, fine.
Dr. Patwardhan, you have to say something? Would like to say something? Okay. Thank you. There are no more questions.
I think Dr. Savji sir, I do have one question, I think, if we could take it.
Okay.
Yeah, how
Yes, Dr.
frequently you change the filter?
The HEPA filter should be changed according to the manufacturers or the one who installs. He gives you the correct idea of that.
Sir,
The
you
thing
have
is
to
that
validate. You have to
you have to
validate the
validate.
air coming out,
Air,
and
yes.
then you have to decide.
You have to do the CFU, that is the colony
You
forming
cannot
unit
put it
count.
like in intervals, because
Yes.
if your theater load is much, even you may have to do it in 3 months.
Yes. For
Sir, I do have-
average load.
And it also depends a lot the area where you practice.
Yeah.
Because if you are practicing in a city where there is a lot of pollution and air quality is bad, your laminar airflow is going to get clogged very soon. So it depends on the area where you practice. That's also very important.
Absolutely.
Sir, I wanted to just ask the medico-legal implementation if the laminar airflow is not there. Are there any cases like even though NABH is recommending it?
So there is enough evidence now to show that laminar airflow is not a must. Enough evidence. So I don't think medico-legally there would be a problem. So my suggestion is, before installing laminar airflow, please go through all the literature and then only install. Because people who are going to sell laminar airflow, they're bound to give that kind of evidence. But
Sir,
I'm sure if you read enough literature, most of the people are not in favor of laminar airflow.
Medico-legally, can I speak medico-legally? Documentation is very important.
Yes.
And authentic documentation. So in this particular part, Maharashtra Orthopaedic Association can give a statement or something of that kind, that the laminar airflow is not a mandatory for joint replacement.
Exactly.
That can be used as evidence by the doctor in the court of law.
Yeah. Actually, we can publish a small booklet or recommendation after this meeting.
Ajit, when you write a chapter on this, so please write a footprint that these are the some of the observation.
Yes, sir.
Because because that book will be a very good book for all reference purposes. So you write in such an article that in the end they should understand that the laminar flow is not a must, but it is optional thing.
Can I add one thing over here?
Yes.
What I could understand is that NABH recommendation. I personally feel NABH is giving recommendation. They are not giving guidelines onto it. So we should kind of go towards guidelines rather than recommendation. So that's what I believe. Like, no, NABH is giving recommendation.
No, but actually we had
and guidelines.
We had a recent inspection of NABH in my hospital, and specifically in the OT they asked, do you have a HEPA filter, do you have laminar flow? If I had said no, then probably they would not have given me a NABH.
Not only they ask, when did you validate it?
Yes,
they ask for validation report as well.
So they ask, but then if we could produce enough evidences to prove our point, probably we could, fight against this. Okay, it is not a must. That's something which we should consider, kind of. As Dr. Agashe rightly said, that, read literature, find out, and then have studies and all. So that will definitely help us.
Yeah, we should have guidelines because sometimes joint replacements are done in small or medium sized operation theaters also, and they cannot afford laminar airflow.
Absolutely.
So we should have a written things which says that it is not a must.
Okay.
So we can produce it in the court of law.
Chandak,
That's
will
what
you share
I mean.
your screen, please?
That's why I mean that MOA or a state level association, even I can get it at the Indian Orthopaedic Association also. At the national level, if there is a one statement of this kind, or you can say not only guideline, it is a recommendation that it is not a mandatory to have laminar airflow for joint replacement surgeon, and there is not enough evidence that absence of the laminar airflow is the main cause of the infection. These two
Ajit had shown articles saying that it is not must.
Patwardhan sir wanted to make a point here.
Rajashekharan says that he has 17 operation theaters. 8 of them are with flow and 7 are without flow. And he says infection rate is same. It has not made any difference, and that is why they have not installed in other theaters.
So we should have
let us end this discussion. May I request Dr. Chandak to share his screen and start his talk, please?
Sir, Sandeep has to say something about this. Sandeep.
Okay.
So just one comment here is that I agree with Dr. Karne. There are two parts to it. One, is laminar flow really required? And second, we should have a consensus statement from MOA in writing. Unless we create literature for ourselves, it will not be possible to defend ourselves in court of law. So MOA has taken the lead. We should put it in paper in the note that this expert group has concluded that it is an desirable requirement, but it is not a mandatory requirement.
Thank you, Sandeep, for your input. And in the book, probably he will write a note, and we can use a disclaimer also, we can put it inside. Okay. Chandak sir, continue.
Yeah. Good morning, all seniors and dear friends. I hope my screen is visible, sir.
Yes, it is visible.
Yes.
Yeah. So OT light and table are essential ingredients of our theater. The first operating tables of the 19th century were primitive but served the purpose for surgery. The most basic general surgical table we all worked in our 80s and 90s. They are simple, had no electronics, but last your ortho lifetime. But the change of position is manual and interfere with the draping and the sterility zones. Side tilting, Trendelenburg, reverse, everything has to be done manually. The most modern operating tables give a lot of choices. They could be static, fixed when they are required for gantries of the modern imaging machines, or dynamic, can be moved, hydraulic and electric as well. And when you are resource surplus, when you are achieve a lot of surgical experience. You can have the most modern of the surgical tables, which are elite, very elegant, and serve all the purposes. There can be two choices of OR table with traction attachment. It could be floor model, as we all learned in our government institutes, or they can be hanging, which help the C-arm imaging, and the C-arm can be easily moved. When hanging attachments are used, apply adjustable leg support. It is useful so that the joints do not get disturbed easily. Friends, what is a good OT table? It should be versatile, can be used for any surgical use, easy to use, reliable, adjustable for height. We need a minimum height for spine surgery because there are bolsters, and we need a high height for neck femur, where the image intensifier has to go beneath the table. The accessories should be easily fixable and should be available as per need, and should be good for infection prevention. We in our era started with general surgical table with orthopedic attachments, and now are fortunate to have good radiolucent table, which are now widely available. The attachments we can have according to our use. Say, for example, for orthoscopy of the shoulder, etc., one may have a shoulder attachment. For spine surgery, good prone attachments. Pay attention to a pediatric attachment. Your height, length of this bar should be most minimum so that you can put a leg on traction even for a pediatric patient. Sidearm boards are quite useful. They can be self-designed or can be obtained. But what I find most useful is our own design tables, which can have the required things of the required sizes. So I usually have large, one small, and a narrow one. And they can be easily made from a backlight sheet. These are very simple sheets available, and you can design them yourself. For olecranon surgery or supracondylar fracture for the prone position, we like to have a large board, wide, and a narrow for a pediatric or a thin patient. For a comfortable lateral position, when the patient is for a supracondylar humerus surgery on a prone position to elbow, the patients are very uncomfortable. And this special piece accessory on the table is very useful, where the shoulder goes into a gutter, as you can see in this. And these are commercially available, or you can design it yourself. They are very useful. Both patient and surgeon should be comfortable for long surgeries. For patient should be comfortable on a jelly pad, and the surgeon can be comfortable on a traction reduction mat. Certain positional teams put an arm board for the patient in bit less of abduction so that they are comfortable. Also, you can put a slight inclination. There are various positions and variations on modern orthopedic table, like a lawn chair position, reverse Trendelenburg. Just pay attention that these mattresses onto the table are non-sliding. They should have a fixing attachment. Lateral decubitus is also very important, commonly used. Pay attention to the padding, and all these attachments should have multiple joints, and they make the life easier. Elite lateral position, as we discussed, is very useful, and this helps avoid pressure to the patient in the shoulder position. Sitting position attachments in modern surgical tables are very useful for shoulder surgeries. Friends, why do we need proper positioning and all those attachments? To maintain patient's airway, to maintain proper circulation, to prevent nerve damage, etc. Many times a cortic cord or a suction tip slips from the draped field, and a small Trishul type surgical anesthetic screen helps us out. So you put a screen on that, press the linen, and then that becomes the nice holder like this situation. When the arm board sags down, a simple corner support can help, and you can tie and fix up a temple. This is the backlight sheet which you can design yourself, large, small, or wide one. Friends, beware of complications on a traction table. When you give traction vector, the ipsilateral perineal post would cause less pressure rather than opposite pressure port. When the amount of traction is there in a complex subtrochanteric or a neck femur patient, and more than an hour is required on a table, we must always pad it. And these are commercially available products from Action, and they are very useful and very protective as well. Operating rooms are stressful, complex settings in which there are a lot of ergonomic risk, and pay attention to all the small details of shifting, etc. The easy, we must ensure a easy patient shifting ability on your table. We must save our bags for good comfort. Orthopedic table must have accessories which are useful like small positioners for small positioner for forearm, etc. The table should have good compatibility with C-arm positions with the table height available. OT table accessories of spine table. These are our own OT table for spine surgery, and so that they create enough flexion in the surgery. And this is the patient layout, and a flexible armrest also helps give a good position, and the anesthetists are also very happy with this table positioning. A railing to hold all the clamps is useful in theater for locating them when we need them. All tables have a lot of railings and a lot of these clamps, and they should be available so that we can attach different attachments. Various positioners and blocks make our surgery easy and help in fracture alignment. An eccentric perineal post is a must for neck femur surgery so that we lead to an unobstructed imaging in the field. This attachment, though I bought them, but they were never used, a split leg attachment, but some specific purposes can be useful. Coming to OT lights, we had halogen and the modern day LED light. The human eye is best adapted for vision in normal light, and the modern day light should avoid glare, shadowing, or visual stress to us. The light is measured in terms of lux, and the lux intensity has to be between 1,20,000 to 1,60,000, which is the best, and choose a light accordingly. The color temperature, the central illuminance, the light field center, all these aspects we have to take into account when we choose a proper light. The depth of illumination, you can simply look at the light beam and see the depth of illumination that we require in spine surgery or in depth of surgeries. The color rendering index is also very important, and the modern LED lights give us this very nicely. The depth of illumination works best at around 1 meter distance, and this is the surgical field which is should. So by and large, don't keep the light dome quite low down. It should be at 1 meter height so that this area we get for working, and which is the parallel beam. The light selection, what should we purchase? Should be a team effort. However, in a single nursing home owned by ourselves, we have to choose all this. Look into aspects of all this. This should have a very good choice. What to select? A dual light system. In cardiac theater, they have triple domes, and in a hybrid OT, they have triple or double dome with 2 monitors. So it depends on your choice what you can select. The technology, halogen is now almost outdated because the bulb becomes very hot and you have to replace the bulb quite often. During the surgery, they also go away. No dimming is possible, and they have very low shadow resolution. The traditional LED lens technology and the modern LED reflector technology, this is the best, and these are quite compatible with the laminar airflow as well. The light field diameter also has to be looked into when we select the light, and the shadow resolution has to be very good. The positioning of light depends what type of surgery you are doing. It depends on the surgery. Close positioning with the homogeneous light field, approximately 1 meter from the surgical field, is the best. OT light prefer to use an inbuilt camera so that you can have a proper surgical recording, and then somebody else is not required to come into the OT field. Focusing in depth requires selection of LEDs. Look at this light dome. So this is depth focusing. In this, there are certain lights, LEDs, which are off, and there are certain on, and that gives a parallel light beam into the depth, and that gives a good field. Autoclavable handles are useful when field changes are quite often required. Pay attention to their, and you can keep 2 or 3 sets so that you can change. Approximately half an hour or 1 hour, then you are skeptical whether they are sterile, so you can change it often. Friends, what makes a good OT light? You have to select properly. Superior light quality, good lux, superior hygiene and durability. And then previously we used to have a lot of bulky domes, but now with the LED screens, these are available quite easily. They should be versatile. A good OT light and a table is a surgeon's delight and is a must for good OT. And if you have a good table and OT light, it's always a pleasure. And office automation also can help in light off. So with modern automation, Alexa, fan off. You can dim or off the light so that you can record your surgeries and have a good video without bright OT light, and then could have a good field. Thank you very much for a patient listening. I would stop at this moment.
Thank you very much, Dr. Rajendra, for a very nice and informative talk. and keeping up to time. In fact, you are 1 minute early.
Thank
So
you,
we have 3 or 4 minutes for a discussion. And if anyone has any suggestion, inputs, questions, you're most welcome.
Wonderful presentation, Chandak sir. I am always learning from you. And he is a master in designing the instruments as well as accessories. And if anybody has queries regarding the operation theater of any kind, please try to consult Dr. Rajendra Chandak. I am proud of him. Thank you very much.
thank you, sir.
So if there are no more questions, I'm sure he has clarified all the doubts and explained very well. Thanks a lot, Dr. Chandak. May I request Dr. G.S. Kulkarni to share his screen. He would be discussing operation theater asepsis, a very, very important topic. Fumigation and infection control. May I request Dr. G.S. Kulkarni, sir, please.
Sir, I am proud to present here the senior most experienced faculty of Maharashtra Orthopaedic Association, not only Maharashtra, but Indian Orthopaedic Association, internationally acclaimed, and he has graciously accepted our invitation for this small webinar. I thank you very much, sir. Kulkarni sir, you are my guru. Thank you and welcome, sir, here.
Sir, instead of 12 minutes, I'll put alarm for 14 minutes.
No problem, no problem. There is some difficulty in sharing screen, I think.
No problem. We can have one or two questions.
Chandak sir, I wanted to ask, you prefer a single dome or two domes? Which one you prefer?
Yeah. So ideally it's two domes. It reduces the shadow problem. Secondly, light both the angles. It is good for assistant yourself. So for certain surgeries, you need only one dome. Like for neck femur, if you're operating on a fracture table, you need only one dome. It doesn't come in between, and the CM adjustments are very easy. So it depends on the type of surgery. A non-union may require two different fields, say for iliac crest graft and a femur distal. So you can put two domes.
How many of you use headlight, especially during doing surgery deep in the cavity or spine? How many of you use headlight?
So if I'm answering that question, sir, previously when the good lights with depth were not available, we all tried those headlights. But what happened with the head movement, the light used to shift. For the assistant, it was a sort of difficulties. But we had used them. But now with the good lights, which good depth penetration with LEDs, I think they are less used.
I find it.
You use the sterile handles to adjust yourself, or you ask somebody to change the position of light?
So sterile handles are for ourselves to use, but I keep set of 3 autoclave so that after 1 hour to 45 minutes, I would change them, because after 1 hour, you're not sure whether somebody's head has touched it. And if some assistant or some surgeon is of a large height, then they might have inadvertently touched. So that is both useful as well as a scary situation as well.
Just one comment here.
Yeah.
I've always found the flexible arthroscopy light to be very useful when I'm doing small surgery in depth in cavities like cysts, or when I'm excising a fascial bar. Use of dental mirrors and arthroscopy light source is also a good additional equipment for looking into absolute minute small cavities after curettage, or if you're going to do fascial bar excisions to look at the periphery. So everybody, if possible, should have a flexible light source which is autoclaved or sterile, basically.
You can UTO them.
We use it in the cemented failed prosthesis from the femoral canal. You can insert into that canal and see, identify the cement and can remove it. Yeah, that's a good suggestion.
Very, very useful tip.
Great, great. And how do you use dental mirror, Sandeep?
So
Can you
what
just
what
explain
happens
about
is that,
dental mirror?
yes, sir, when we are excising the facial bar or we are curating a cyst with irregular cavities, when you put a mirror into the cavity, it shows you like an inclination, a different angle, so that indirectly you can visualize things we otherwise can't see.
Hello.
So small dental mirror which is autoclaved, you can push into the cavity and turn it around, so it shows you different angles.
स्क्रीन शेअर होत नाही आम्ही स्क्रीन शेअर केलंय आणि ते तुमचा इथला आमचाही आवाज तुम्हाला तिकडे येत
Sir, have you bought a new laptop? Because the same thing had happened to me. I could not share. Is it a new laptop?
Yeah, I cannot share and I cannot. You are
so
not.
Is it a new laptop?
Are you using a Mac?
System preferences. You have to go to system preferences.
Yes, sir. So what we will do, can we move on to the next lecture? I will.
Yeah, maybe Netra can do first.
Netra
Just
will
1
come.
minute.
Sunil, please see to it.
Sir, what I will do is that I will help him out. Can you move on to the next lecture?
Yes,
Okay.
yes.
Netra, please share your screen.
Yes, yes.
So it's our pleasure to introduce Dr. Netra, who is CSSD chief at Hinduja Hospital for last 15 years or so. I have been working very closely with her. And welcome, Dr. Netra here.
Thank you, sir. Let me just go to the first slide.
Make it full screen, madam. Okay.
Yeah. Thank you. At the outset, let me thank Dr. Agashe for introducing me to this esteemed forum and giving me an opportunity to talk on sterilization method. And also thank Dr. Wasudeo, who's president of MOA, for allowing me to share my knowledge. So I'm actually going to talk about sterilization methods and principles of autoclaving. Objective over here is to have an overview on sterilization methods and discuss principle of sterilization and factors affecting the sterility. As we all are aware, basically the sterilization methods could be categorized under two categories. One is high temperature and another one will be low temperature. In high temperature, we will have steam sterilization and dry sterilization. The difference between steam and a dry sterilization would be a steam will have a moist sterilization. So there's some percentage of moisture when we are sterilizing anything into steam. And dry heat is absolutely dry. There is no moisture involved in sterilization method. The low temperature sterilization will be gas sterilization, which is EO, then plasma, then LTSF. LTSF is a low temperature steam formaldehyde, which is a combination of low temperature, that is steam, and formaldehyde. So that's how the sterilization occurs. Then chemicals, we all are aware of different chemicals which are actually high-level disinfectant, and there are few which are sterilant. To name, OPA is a sterilant, butadiene is a sterilant, and of course the sterilization parameters differs from modes of sterilization. And the last is radiation sterilization, which actually encompasses a variety of types of sterilization, which includes gamma radiation, electron beam radiation, X-ray, ultraviolet, and microwave. So these are the different methods of sterilization. Moving towards the topic of principles of steam sterilization. So we all know that steam is fastest, cheapest, and safest mode of sterilization, which is readily available, which is turned out to be very safe and very fast. Now, any basic principle in any kind of sterilization is anything which is not clean, unclean, or it cannot be sterilized. So nevertheless, the baseline, we all should remember that sterilization has to have basic cleaning processes perfectly all right. Then only we can achieve sterilization. We have seen evolution of sterilizer, right from the basic sterilization modes, wherein we used to sterilize in ancient age. We used to sterilize probably by boiling. Then we moved to pressure cooker. Then we moved to manual operated machine, and then now we have high-tech machines which are PLC control and all. Once again over here, the difference is when we used to use cooker or this manual operated machine. So the smaller machine does not have a jacket which can control the temperature, which is the most important, one of the most important criteria in sterilization procedures. So that is how your effect of sterilization is lesser than when you move to the high-tech machine. In manual operated machine, once again, it's manually controlled. So anybody can change the parameters of sterilization. So wherein we again are not so confident about the end result. So preferred methods are, you have high-tech machine wherein everything is PLC control. You can't adjust anything. You have to set the parameters of sterilization. You have all your utilities in place. They are, controlled and they are checked by the machine while it is in use. And then the end result is that you get 100% sterile products out of it. So looking into types of sterilizers, there are, it could be categorized into main two types, wherein you have a gravity sterilizer and vacuum sterilizer. So gravity are nothing but, there's no vacuum. The air is removed through pressure. So they are called as N type of sterilizers. And there is S type of sterilizer, which use a fractionator, which use a single vacuum in the process. And B type are one wherein you have a fractionated vacuum, wherein your vacuum pump is so effective that it eliminates all the air within the chamber, which is the main hindrance in sterilization process. Because anything which, if you have air into it, which are air pockets, your steam is not going to penetrate into it. And the last one, I called it as flash, which is the terminology which is used is immediate use steam sterilizer. So basically, flash sterilizers are nothing but the sterilizers which are, or the immediate use sterilizers are the sterilizers which are supposed to be used immediately. Anything which, during the procedure, if anything falls down or anything becomes unsterile, and if you want to sterilize it, you just put it in this immediate use sterilizer, sterilize it, and you don't use any wrapping material to it. Sterilize it and use it immediately. That's why the name nomenclature is changed to immediate use steam sterilizer. Now, phases of steam sterilization which are important in the processes. One is the preconditioning. Then you.
Excuse me, Netra. Dr. Netra, let me interrupt you. When you say immediate means, how long does it take? If you could just tell us, or are you going to explain in your next talk?
Otherwise, I'll explain about immediate use steam sterilization. It is actually, earlier we used to call it as flash sterilizer.
Right.
So flash, the terminology of flash is changed to immediate use sterilizer. So it all again depends on, you do not have a wrapping material to it. It's an open instrument which is sterilized. So time taken for sterilization of this any product is reduced. So if you are going to sterilize anything traditionally, which with wrapped items and all, it probably will depend on the type of, items which you are processing in and on. So over here, your time could go between maybe 10 minutes, not less than 7 minutes.
Okay.
Between
So
7 to
in about 10 minutes
to 12
time,
minutes.
you can have a sterilized product.
Sorry?
In about 10 minutes time, you can have a product which is sterilized with flash.
Yes, but we don't name it as, we don't call it as.
If you could explain about other sterilizers, people will be happy.
I will. It's there in my presentation forward.
Do include how reliable is a flash sterilizer?
Yes. It's 100% reliable. Once again, I call it as immediate use sterilizer. So it has to be within the operation theater, wherein you are going to use the instruments. You are going to not pack the instruments. So your sterility maintenance affects over there. So you use it very, 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 very minimally. So use it only.
Yeah, one thing I want to ask.
Emergencies. Sorry.
One thing I want to ask. Suppose we require certain implant which is to be implanted inside.
No. Implants cannot be flash sterilized. Absolutely no ways. Because then you are into risk of contaminating infection to the patient because you are using it, unwrapped.
First, madam, you continue your lecture and then we'll have a group discussion.
Sure.
Yeah, sure.
I'm sorry for interrupting you.
So phases of steam sterilization are basically, there's a pre-treatment which happens wherein you remove all air from the chamber, from the packs and all. Okay. And then you moisten the pack so that it facilitates the sterilization. Then there is something called as sterilization or exposure period, which again depends on various factors. What are you going to sterilize it? How much time you need it? So there are different IFUs, instruction for use for every item. We get it from the vendor. You ask the vendor and he will give you these IFUs stating that this particular item will need this particular temperature and time for sterilization. So that is how you keep that sterilization time for any item to be sterilized. And at the end, there is a post-treatment which actually normalizes the temperature and moisture content within the chamber. And you get dry instrument for use, which is once again a must for any surgeries. So these are the factors which actually affect the sterilization methods. As I said, you need to have everything clean properly. So when you have cleaning, you have different kinds of brushes, and the brushes used for cleaning should be soft brushes and not the hard brushes, because then it can actually damage your instruments by having scratches on instruments and all. So you get these brushes readily available in the market, so you make use of it. And then do not use abrasive powders while cleaning any of the instruments, because again, abrasive powders are the ones which are going to have scratches on your instruments. Now use your chemicals appropriately, though it is recommended to use multi-enzyme product, which actually is a fast cleaning agent and immediately cleans everything, and that obviously has an effect on sterilization. So in the market, you have various multi-enzyme products. The one which you choose, you have to, kind of once again see to it and read it thoroughly and get an effective one, which is useful in your setup. And then when it comes to packaging material, we all know that linen is the most widely used packaging material as of now in India. But we do have non-woven material. We have peel pouches, which are a good packaging agent. So when you have packaging material, the criteria for selection for packaging material would be, it should be non-toxic, then it should withstand the weight of the pack, then it should give you the product safe for handling, then also it should allow your sterilant to penetrate through and through, and it should be a good microbial, it should carry a good microbial count. So when you talk about linen, the microbial count will be, holding capacity will be less, because linen is a porous material. So linen ideally, though it is not a good packaging material, but and the other packaging material are a little costly. So we should in future move towards from linen to the other packaging material. Now loading is another important factor in terms of sterilization. So the picture which I have captured is from an abroad sterilization method, wherein how you stack your items, you should not stack it too tight. There should be a gap between each pack, so that your steam penetrates, your air removal is easy, and again end result should be all, you get everything sterile. So the loading is also, you cannot jam everything and put it in the sterilizer, so that will end up in wet packs, which again is a cause of concern in terms of sterility. Now, the other factor which affects sterilization is your instrument structure. If you have simple instruments like retractors and all, hammers and all, so which is easy for sterilization, because if you have cannulated items, which are the most difficult in sterilization phase, because you can't see through the cannulas whether it is clean properly, and if it is not clean, it's obviously not going to be sterilizing everything. So your cleaning affects on your instrument. So your instrument structure, then you have your power instruments. So how do you clean those power instruments? So immediately you're used. Now at the moment you have power instruments which can be actually soaked into water and detergent and clean it properly, unlike the earlier one wherein there was no soaking allowed and all. So the important factor over here which we need to kind of remember is that immediately clean your instruments with water and not with any other detergent, and absolutely no for saline, because it's going to have corrode your instruments and it's going to have a bad effect. And as long as the power instrument goes, you need to flush them immediately after the use and try to clean them immediately, and then use processes for sterilization. Now, these are the three main criteria for or factors: your contact time, your time for sterilization, and your temperature. When it is a steam sterilization, we widely use two temperatures. One is 121 and the other one is 132 or 134 degrees. The time for sterilization depends on the temperature. So the lower the temperature, the higher the time required for sterilization. The higher the temperature, the lower the time required for sterilization. And once again, your contact time depends on what are you processing it, what are you sterilizing in. So you need to get your IFUs clear, and then you can, decide on the time factor. However said and done, whatever said and done, it's very difficult because in a setup like us, wherein we kind of, process your electrical equipments, you process your complex instruments, you process your simple instruments, you process our linen packs and all. So your sterilization time will have to be dependent on what is the load and what is the combination of load. So you decide your sterilization time based on your combination of load and not on a particular load. So if IFU states about 7 minutes sterilization time for a particular item and 12 minutes sterilization time for another particular item, so we prefer to keep it, and we must keep it for the longer period of time. So that's how we decide on the sterilization hold time. So last is how do you ensure you need to have your quality control in place. So these are the main quality control methods wherein you check physical methods, wherein you check every cycle of the sterilizer. At the moment, recently we get your printouts of your sterilization process, which talks about your pre-treatment, your stir hold time, and then your back post sterilization time, your drying time. So you get to know whether your desired parameters have met over there or not. Then you have chemical indicator, which actually is put on every item, which we call it as process indicator, which is easy for an end user to understand whether the item is processed through sterilization or not processed, and even if it is processed, whether it is passed or unpassed. However, that's not something which you can conclude on, the item is sterile or unsterile. But these are the indicators which are used for it at user level. Then we have another type of chemical indicator which is used in Bovidec test, which is used for vacuum sterilizers, wherein you check, air removal, whether the air removal is proper or improper. And a leak test which talks about, yes sir, this is the last slide. A leak test which talks about, whether there was a leak in the chamber. And the most important and required is a biological test which should be done daily if your sterilizer is used frequently, and whenever you have implantable load processed in your sterilizer, every implantable load should have this. These are the recommendations from CDC, so we must try and follow these recommendations. I think that's all I could crisp my presentation in. Thank you so much. We could take up, I don't know whether we could take up questions or we could have discussion later.
Please, Baz.
No. Very wonderful presentation. Stop your screen and we'll have some very important point discussion.
Yeah. Agashe sir, you are muted, sir.
Dr. V.N.Deshpande has asked two questions. The first is the very fact that implants cannot be flash sterilized means that it is inappropriate. If it is not appropriate for implants, how can it be appropriate for instruments? Am I right, Dr. Deshpande?
Yes, sir. Absolutely true.
Why do we say that? Can I say, why do we say that implants should not be flash sterilized? Because implants are going and remaining inside patient's body. Whereas when you talk about instruments, it's not going and, though it has a touch on patient, it's not going to remain in the patient body. So there are chances of infection more when the patient, when the implant is inside the body. So that's the reason we say that implants should not be flash sterilized.
Sometimes
and even the CDC does not recommend this.
Yeah. Does that
sometimes we can put them in that some liquid solution or something. Any good chemical in which we can put the instrument for 10 minutes and
side
instruments.
OPA is something which actually
sterilizes. Or any other newer thing.
Yeah. Can I ask you a question, ma'am?
No, I think let her answer Dr. our Bhandari's question. Is there any liquid in which you can put the instruments which get sterilized in about 10 minutes time.
Yeah, because it will be a cheaper thing than a flash sterilizer.
OPA is something which you can actually use as a sterilant within, I think, if I remember correctly, I think it's 5 to 10 minutes you can sterilize it. But then use it. OPA is a liquid which actually sterilizes anything which you put into it, especially the instrument. But it's not recommended because you're going to spoil your. I mean, you should not use it frequently. Only and otherwise, if there is an emergency, use it. You don't use it frequently because you're going to spoil your instruments in the long run.
Okay, then there is a question by Dr. Chandak followed by Dr. Sauji.
Yes, sir.
Madam,
what's the question?
Yeah, you mentioned that moisten the packs. What does that mean?
Sorry?
Moisten your packs. Yeah, you mentioned in your slide that before sterilization, the packs have to be moistened.
Yeah, I didn't say ETO sterilization pack has to be moistened. I said steam sterilization pack has to be moistened. ETO, absolutely no moisture, zero moisture.
And for steam sterilization, how do you moisten them?
No, basically the latest sterilizers which you use has a capacity to use moisture into it. And the recommendation, if you use a cannulated instruments, you put some amount of water into it. It creates moisture inside within when your sterilization process is happening.
Okay.
So then it facilitates the sterilizer. But that how much amount of moisture you keep inside the cannulated thing, also we need to be very particular about it, because at the end we are going to get wet packs. Okay. So the mass density of the instruments and packs also has an effect on sterility.
Okay, thank you.
Dr. Sauji, please.
I want to ask whether to use as drums for instruments. Whether you put instruments in a drum. I use aluminum trays. I just put all the instruments in aluminum tray and autoclave that. So which is better, to put in the drum or put in the aluminum square tray?
Anytime square tray is better, which has holes into it, so that your steam penetration and your air removal is easy. Drum, there are chances of getting wet packs, and even if you're going to use drums, you need to also give importance of what is the mass which you're going to put it into it, and you use it only one time and then don't use it for repeated time, because once you open it, it's going to become unsterile. So preferred method is tray.
Tray. I use tray, sweet mud tray, that aluminum tray where you get in sweet mud, and I cover it with the linen and put the tray
okay.
1 hour.
That's okay. That's okay.
In one
tray
of the similar lectures I have
option.
heard before, in one of the lectures which I have heard before, when you use tray, they say the shelf life of autoclave tray is much shorter than the shelf life of autoclave drum.
Yeah. Drum ideally should be replaced with trays now.
In how many days?
So
Yes, sir.
See, for small nursing home, I use only once, immediately.
Yeah, that should be all right, because once you sterilize and open it, everything becomes unsterile.
Yes,
even if it is in tray, also it's going to become unsterile.
Yes. Yeah.
So question that is raised is, what is the difference between shelf life of a autoclave drum and autoclave tray? Shelf life without use.
If I have to answer these questions, the shelf life of any product, sterile product, depends on the packaging material. So now, if you're using drum, you're not protecting it with any packaging material, right? So it doesn't have any shelf life. Absolutely no shelf life. If you're putting a tray, you are putting it in a linen. So it actually has a certain shelf life, which depends on various factors. So which we have to calculate based on our practices. How do you store it? Where do you store it? How many times you handle it? Whether the air in that particular area is appropriately all right. So once you do all this experiment, do some kind of microbiological testing of the sterile things into it, and then you decide whether you want to keep it for 2 days, 3 days, 4 days, 7 days. But linen being a porous material, there is immediate entry of microorganisms because the holes are open, and then you have tears and lot many things. So it's not a good, of course, not a good packaging material. But once again, shelf life depends on packaging material, and you decide your shelf life. You decide doing this exercise. Maximum should not be more than, to my experience, should not be more than a week. That's the maximum which you should store it in linen.
Madam, in small hospitals, it is usually the drums with vertical autoclave which I use. And usually they do it once in a week. So is it a good practice or they have to change it?
See, drums, the whole point in using drums is that it does not have a covering into it. You have those, kind of openings over there to allow the steam to penetrate. You close it for sterilization. In my younger age, when I started my CSLD, we used to have those drums. Okay, so wherein you used to open it, and then post sterilization in your sterile area, we had a sterile area. So in your open area where we do not know what is the air count or microbial count of that particular area, you're closing it. So there are chances of, some air which has gone inside the drum. Okay. So that's how once you open the drum, it becomes unsterile. So use it only once. You keep it for a day or whatever time frame, which once again you need to calculate it. How much time frame you are going to keep it. But once you open it, you just have to treat it as unsterile.
Okay. Last question by Dr. Sauji. And then at the end, Netra, if you could just tell us, what does CSSD stand for?
It's actually Central Sterile Supply Department, wherein unlike other hospitals, wherein sterilization happens at various places. Somebody does it at dental OPD, somebody does it in OT, and then various OT you have, sterilizers. So your control of sterilization is going to every person. Wherein if you have a centralized CSLD, your control of all these activities of cleaning, packing, sterilization, it under one person who actually takes care of all this, so that at the end you get sterile product. So that's the concept which has come in India about maybe 20, 30 years down the line.
Agashe sir,
Dr.
Agashe sir,
last question.
Agashe sir, we must get some inputs from HOD AIMS, Dr. Alok Chandra Agarwal also.
Oh yes, sure. So closing remarks by Dr. Alok. After
Actually, the
questions.
Program is going on very good. We started with the history, OT temperature, pressure, and now sterilization. So we are going with the sterilization of the equipment very nicely going on. And there were questions about cannulated sterilization. There were questions about the strength of the OT table, whether it should be mounted or it should be movable. When we are giving traction, maybe a mounted table with 350 kilograms of strength will be better. And then for the Netra, things were coming like this, that can we use liquid hydrochloric acid for the instruments which fall down immediately to be used? Because otherwise we will be killing only the vegetative forms and not the spores which have now come in the micropores. There are questions which are going to come now with this lecture coming on as to if the flies come inside, mosquitoes come inside the OT, then how are you controlling them and whether you should go for formalin sterilization or not. So it is a very interesting session. And my whole department of the 30 boys are sitting together and seeing it. So let us continue with it. Thank you.
Agarwal, thanks a lot. So it's my pleasure to invite Dr. G.S. Kulkarni. He would be talking on asepsis in OT, fumigation and infection control.
Yeah, can you hear? Can you see my slide now?
Yes, sir. Yes, sir.
Yes, sir. Okay. Asepsis in OT, fumigation and infection control. Infection is the greatest enemy of orthopedics and is the cause of failure of surgery. Great suffering of the patients, financial burden, and surgeon's reputation is at stake. However, exactly the OT complex is to reduce the infection. Design is very important, whether it is a small hospital or a large hospital. Outer unsterile zone, middle semi-sterile zone, inner sterile zone, OR. The OT design is outer unsterile zone should have a reception, patient dress and trolley change, patient examination, video and counseling, and store and waiting area. The semi-sterile zone should have a change room for doctors and nurses separately, and a recovery room, store for dirty and clean items, OT dress, shoes, etc. And the sterilization area should be in the semi-sterile zone. The most sterile zone is the OT room, maybe 1, 2 or more. Now, it is very important that the pre-operative hospital stay should be as less as possible, preferably 1 to 2 days, and day care is ideal to prevent hospital infection. Patient examination at the entrance in the unsterile zone is if he has got any illness, any disease, cough or respiratory disease. Bowel evacuation is important. Blood pressure, check the blood pressure, blood sugar and other comorbidities, oral and dental hygiene, any skin lesion, fungus infection, etc. at the operative site should be checked. Cleaning and sterilization. Dry the instruments before packing for sterilization. Paper wrapping is better and more reliable than cloth wrapping. Chemical indications are important. Strips should be used, one inside and one outside the container. Avoid overfilling the containers because the steam will not enter into the overfilled container. Record is important from the MLC point of view. OT walls and floor should have no crevices. Now, the sterilization zone should have a cleaning room, enzymatic. The packaging room should be there, and sterilization room and sterile storage room. These all 4 should be separate ones. Enzyme cleaning of instruments should be done and use the enzyme and then clean it. ETO avoids repeated sterilization of implants. Autoclave is temperature should be 121 degrees, 30 minutes of should be there or maximum 45 minutes. Allow 15 to 30 minutes of drying. Avoid flash sterilization because it becomes very difficult to carry the sterilized material from flash sterilization to the operation room. If at all you want to have a flash sterilization, it should be either in the operation room or just outside the operation room. CSSD is ideal and is preferred. Laminar airflow has been discussed. Laminar airflow is not needed at all. Those who have may retain it, but what is important is properly maintained. It should be properly maintained. Otherwise, it is more dangerous. UV light should be there in the proximal to the HEPA filters. Now, air handling unit is a must to control temperature at 21 to 23 degrees centigrade, humidity 40 to 60 degrees, air pressure inside. OT should be more than outside. All these are done by AHU. Therefore, whether you use a laminar airflow or you don't use, AHU must be there. And therefore, the cost of laminar airflow is not much of a difference, but the maintenance is bothersome. Water supply. Check the hardness and bacterial count regularly, the water you are using in OR. Borewell water is usually hard. If possible, don't use borewell water, but if you have to use, then softening of the water is necessary. Microbiological testings of the water should be done at least once a month to detect the pathogens. Care of water storage tanks must be done regularly and should be checked. Check the covers, whether they are not covered. Sometimes they are not covered or improperly covered, and then dust gathers into the water. clean and disinfected at least once in 3 months. Clean tanks with sodium hypochlorite. Air bioburden, you should use microbiological monitoring. 2 settle plates, one on the table, one in the corner of the operation room. Bacterial count and type must be recorded, and keep records of all these things for medical legal purposes. Air conditioner units in OR is a source of infection, and therefore, as far as possible, do not use air conditioner unit in OR. But if you have to use in a small hospital, then you must keep it, maintain it properly, wash it every week. Surface cleaning and disinfection is the highest majority, as important as sterilization. Start of the day should clean all horizontal surfaces, the floor, the table, and if you have any walls, horizontal walls, etc. See, this is the machine used for sterilization. Surface cleaning and disinfection. End of the day, scrub the floor with high level of disinfectant, then fumigate. Periodical detailed wash down is important. Wash and disinfect entire OT complex, all OTs, rooms, passages, at least once a week. Use wet mops or cleaning machine. Surface cleaning and disinfection. Walls should be cleaned 2 to 3 times a week. Between surgeries, clean blood spills with sodium hypochlorite. Disinfect large equipment like OT table, etc. Finally, the floor. Adequate time should be given, at least 30 minutes between the 2 surgeries. Bioburden inside OT, protocol of personnel. Bacterial count tremendously increases if the persons are more in OT. There should be ideally 4 or 5. More than that is dangerous. Minimize movements, not a place for exercise. Less talks, especially the anesthetists. They are to be watched for and told them not to talk. Pass all sharps in a kidney tray. Fumigation reduces the bioburden. Formalin is strong irritant, therefore not used now. Currently, glutaldehyde and H2O2 are used. Effect of fumigation is temporary to reduce the accumulated bioburden, but is needed in Indian OTs. Methods may be hand spraying or fogging machine as I shown above. Surgical attire and drapes, preferably disposable paper gown and drapes. But there is not much of a difference between use cloth gown and a paper gown as regards the infection rate is concerned. If clothes are used, it should be tightly woven. Pore size should be less than 80 microns. Cotton and polyester ratio should be 50-50%. Never use pure cotton for any drapes or gowns. Use waterproof shoes. Protocol for OT person. Cover all face and head hair by cap and mask. No door opening. Bring in all the required implants and equipment. Make a checklist of items required. No traffic in and out OT. Use pass window as you see here. The pass window is important, so to avoid the door opening. Surgeon should avoid seeing OPD patients or visitors in OT complex. Anesthetist should avoid coming out of OT to ICU or other OTs or for a cup of tea or toilet. Avoid keeping hand on abdomen or folded into axilla. Preoperative planning checklist saves time and reduces infection. Preoperative checklist, steps of surgery should be noted down. Checklist of equipment and implant required. Preoperative checkup of the patient and anesthesia checklist. Scrubbing. Basin should be very clean and disinfectable. Scrubbing should be clean the nails, very important. First scrub with liquid soap and water, then betadine or chlorhexidine. 3 to 5 minutes of scrub is enough. The scrub above elbow at least 1 to 2 inches. Before donning gloves, dry hands with alcohol. Care of operative site. Hair at surgical site is not removed. If thick, only the surgical site about diameter of 1 inch and the length up should be the probable incision length. It should be trimmed and not shaved, and it should be only in OT only, not in the wards. First clean with soap and water, then with Savlon, then with betadine or chlorhexidine. Finally, dry with alcohol. Allow disinfectant to remain on the skin, betadine 1 to 2 minutes, chlorhexidine half to 1 minute. Antibiotic prophylaxis, Vikas is the authority on this, but what we follow is like this. Antibiotic prophylaxis, we use cephalosporin 2nd generation. However, this may vary in different hospitals depending on the hospital bacteria and sensitivity. Avoid using more than 1 antibiotics. First injection should be 30 to 60 minutes before incision. Second injections 10 minutes before tourniquet. Third, if the operation is more than 4 hours, then third injection should be given at the end of operation, and then 8 hourly for 24 hours. However, if there is an open fracture, we give antibiotics till the skin closure, usually 5 to 7 days. Infected non-Indian may require weeks of antibiotics. Disposal of biomedical waste is very important. Collect infection, waste and sharp separately during surgery. Use thick rubber gloves. Remove waste as early as possible. Surgery of HIV patient. No special measures are required. Standard disinfectants and disinfection procedures kill the virus. Disinfect linen in 1 to 2% sodium hypochlorite solution. Proper surface cleaning and disinfection of all surfaces. Proper use of barrier precautions. Waterproof OT attire. Use goggles and face shield. Careful handling of sharps. Use kidney trays. Microbiological survey is important. Regular microbiological sampling of surfaces, air, water, preferably once a week. Use both settle plates and air sampling. Settle plate informs the organism of settling on it. Sampler provides the information about suspended in air, for example, the fungal spores. Intraoperative air sampling is important because plate placed close to the incision or on anesthesia machine to detect the pathogens present only during surgery, for example, the MRSA. Surface swabs indicate efficacy of the surface cleaning and maintain the record. Air sampling is a cleanliness of the air for fungal spores which are not picked up on plates. OT staff health. Person with respiratory tract infection with cough or a draining skin lesion should not enter OT. Vaccination should be there. All personnel must get vaccinated with hepatitis B, COVID-19. Check antibody levels. If low, revaccination. Staff encouraged to keep fitness by diet and exercise. Now, lastly, very important, this last few slides, surveillance of program for surgical site infection. There should be a team should be there, whether the hospital is small or large. There should be a team, the surgeon should be the chief of the team, trained biochemist, surveillance officer, and a trained nurse. So functions of the surveillance committee is microbiology data collection and analyze to find responsible organisms and their sensitivity in a particular hospital. Find possible sources, trend of infection, developing antibiotic and treatment policy. Keep record and analyze each infected case and interpret. Measure and prevention of infection. note surgeries and infection rate of a surgeon and inform him or her about her increased rate of infection and to find out for herself or himself the cause of infection. In one of my institution, the surgeon was allowing so many people to come in and see, and the infection rate was more. So develop protocol in wards, OT, visitors, and hand hygiene, etc. Monitor protocol to find lapses and treat them. Develop hand washing culture in the entire institution. Thank you very much. Thank you very much.
Thank you very much, sir, for a very informative and interesting talk. I'm sure there would be many questions. First question is, if patient passes stools on the operation table, would you postpone the theater, postpone the surgery, or what would be your protocol?
No, we had 2-3 times such a thing. Then we remove the patient and clean the surgery, fumigate it, keep it for 1 hour, and again do cleaning. And on the same day we start, but it is delayed by about 2 hours or so.
Okay.
But we do on the same day.
Okay.
But sir, is there any possibility of soiling the the ground? And it is very difficult to remove everything dirt of a very deadly bacteria.
Oh, with the machine and with the machine cleaning and machine everything, it can be done. But another thing is we put drapes around the anus and this just covered it so that the stools do not usually fall on the ground. It is there inside, and even if it is small quantity falls, which we come to know, and but then we clean it up. It can be cleaned. I don't think it is.
Unfortunately, patients pass stools after giving spinal anesthesia.
Yeah, spinal anesthesia.
So the patient is already anesthetized and then passes motion. Then surgeon is in a fix.
Yeah, that's right.
Yeah. But you can actually nowadays put adult diapers, especially elderly people. You can put adult diapers when they are being taken in the operation theatre for any
surgery. If you are doing a fracture neck femur fixation, and patient passes, you can't use diaper also.
Yeah, but that's you can really remove on that side. But still, it is a better thing than soiling the whole theatre and the table.
Yeah, I think there was a hand raised by someone. Chandak, right.
Sir, you said at the beginning of theatre, mop all the horizontal surfaces. The theatre is already fumigated. So do we need to do at the beginning or do we at the end?
Yeah, that's right. Good question. Fumigation is very temporary. The fumigation is just cleans up the area, but once you open the door, there is a the air comes in with the dust and infected material. So it is a precaution to do a better cleaning in the start also. It's a better cleaning. That's the reason. It's temporary. The fumigation is temporary.
Yeah, Dr. Chandak wants to ask one more question.
Sir, all these modern guidelines, absolutely fantastic. All agreed. But in all our yesteryears in your own practice, you must have operated n number of patients without those stringent facilities available. So what is your take and what is the most important thing to prevent infection?
I think the most important is start from the patient comes inside the operation, inside the OPD and admitted. So you should admit at only 1 day or two. I will tell you an incident. My wife was operated for a shoulder arthroplasty in UK by Rangan, and she was investigated everything by outpatient as an outpatient department, and for 2 days she was taken swabs from nose and groin and axilla, and they found out there was no MRSA. And then she was asked to get admitted at 7 o'clock in the morning on the operation date. At 9 o'clock, there was surgery. And at 7 o'clock, she was discharged. See, she was there only for 12 hours. and 5 hours in operation complex and 7 hours in the ward, in the room. So that is, I think, is a very important thing. The second one is your wards must be clean, and also there should be separation of patients. You should not be crowded hospital. So it starts from there. And then the patient also has got internal infection rate. The patient himself is harboring some infection, a blood-borne infection, and then that settles. That also is a cause. So in spite of all taking maximum care, you do get infection, but the infection rate should be, as they in the UK and USA, they say the most modern hospitals have got infection rate 1%. And that is unavoidable in spite of this. So our aim should be that our infection rate should be as low as possible, 1%. Yeah, yes. Because
sir, there is one question from Venu Gopal. He asked whether the air handling unit also needs fumigation.
Air handling, it doesn't need. Fumigation is not necessary. But see the difference between air handling unit and laminar airflow. The air handling unit also should have a HEPA filters. So the difference between laminar airflow and HEPA air handling unit is just a lamination of the air. So it is, the cost is not much, but the laminar airflow has to be maintained. But I don't think there is any need for fumigation of the air handling unit. No, it is just outside, quite outside the theater.
So what is the protocol in between cases, between two clean cases? Or
sir, we are having a separate talk on this thing.
Okay.
In the next webinar.
Fine. Next.
One question I want to ask. Yeah. Dr. Gadegone in the beginning itself said that we are really conducting these things for peripheral surgeons, small and medium. So all we are discussing ideal things, but what minimum guidelines are required for Indian situations, and where the people from periphery are operating in small and medium size nursing home? We should have the minimum things, and then preferable things, and the ideal things. We should all have all these three things, because all these things are ideal, but may not be practical for small setups or medium size setup or for periphery. And our main aim in MOA for this webinar is for the surgeons who are operating in smaller setups. So we should also have the three things: minimum, preferable, and ideal. And we should actually publish like that for court cases and legal purposes.
Yeah, shall I? See, Dr.Sandeep Kulkarni from Kolhapur, biochemist, has written a chapter in my textbook, a very, very nice article. He has written for very small hospitals and large hospitals. I would divide only into two parts. Very small hospitals are not necessary. 10 beds, it is at least 25 beds, or most of the hospitals, and 100 beds. So I would divide into two parts: small hospitals and large hospitals. The small hospitals have the problem of space also. So, but however, whatever the small hospital, the space should be divided into three parts: outer zone, middle zone, and inner zone. You may divide. Suppose, for example, your sterilization room has only one room you have. In that room, you should have a corner made partitions into 2 or 3 parts. One is for cleaning, another is for packaging, and another is for storing. So there should be a separation of these things. You should not keep these sterile parts and unsterile parts in the same. You should not clean the used instruments in one room and keep the sterile items in the same room. That is not allowed. Well, if however small hospital, you should keep as many as possible. In OR, you can control your numbers and all that. So I think to a large extent, even a small hospital can reduce the infection rate by observing all these things. It is not, as I told you, it is not necessary. Laminar airflow is not necessary, but HU is a must even for a small hospital.
So my observation is that in a small hospital, probably the number of surgeons are less, the traffic in the operation theatre is less, and if the surgeon is very particular that operation theatre nobody should enter without any cause or anything, even the infection rates are not that high, even if they don't follow this, probably because the traffic is less, the one surgeon OT and all those things also matter to a certain extent.
Right.
Bhandari
Sir,
sir,
I have
our
a
mission
question.
should go
Sir, I have
that we
a
should
question.
observe all precautions to prevent infection, though it is a small based hospital. Not that whatever we are doing an infection rate is there. There are so many factors, surgical skill and so many other things also. But our message should go that even in a small hospital, we must take a maximum precaution to prevent infection.
Yeah, that's why I said the minimum, what it must be there, then ideal or preferable and ideal, just like in laminar airflow.
So
last question
screen
from
for
Dr.
MRSA?
Deshpande.
Yes,
Just 1 minute, Dr. Deshpande. While Dr. Deshpande is asking a question and which is being discussed, may I request Sandeep to share his presentation? Yes, Dr. Deshpande.
Sir, may
Sandeep,
I ask how
please
many
share your
of us?
presentation.
Sir, may I ask how many of us do MRSA screenings, and how many of us use the ointment into the nose and all that? I mean, I don't recollect the name immediately.
Mupirocin.
For all joint cases, I do MRSA screening.
We do occasionally when the suspect infection, and but nasal we are not using.
Sir, how about the OT stuff?
OT stuff once in a month.
Okay, fine.
Sir, when you write a chapter on this thing, Kulkarni sir, you write not for advanced but for a medium 20 to 25 bedded hospital. That will be our expectation from you.
I would not agree with you. I would like to have both the ideal one as well as the small hospital one.
Okay.
That would be should have both, because then we will be unnecessarily degrading ourselves.
No.
It is better to know what is ideal. How much we can follow is different issue, but it is better to know how much what is ideal.
How you can modify them. That's why I'm telling you, this Dr. Sanjay Kulkarni has written a very good article for everything. He has trimmed down how to do if there is a small hospital, how to do this. Each item he has separately. So we are together. We are writing this chapter, and we'll be having this in mind, that one for the small hospital and one for the ideal.
Okay, sir. Then there will be 2 chapters from you. No problem.
No, sir. The only thing is you should have some proof to show in the court of law. So we should have basic minimum. We should not all write only ideal things, but we should write basic minimum.
This is like asking concession in operating. Bacteria doesn't know whether it is a small hospital or
hospital or a big hospital. Absolutely.
Bacteria will act like them only. So we should go with the ideal, and we should follow all the ideal things. And we should insist also for the small hospitals also to follow maximum.
Sir, many times financially it is not viable for small.
That is not a question. We cannot plead it in court.
Only one I would like to summarize is,
yes, sir.
The small hospital should have a air handling unit properly, and should have a horizontal sterilizer, proper sterilization. These 2 things is a must for even a small hospital.
Okay. That's why I'm saying, what is the minimum required?
Okay.
Yeah, from medical legal point of view also, I want to say one thing.
Can you hear me, sir?
Yes, please.
Hello.
Yes, we can hear you.
Can you see the screen?
Yeah, we can see your screen. Yeah.
Can you see this?
Yes.
I want to make one comment. See, ideal situation is there. The ideal has to be there from the theoretical point of view, from academic point of view. But we are talking again of the medico-legal implications. So in the court of law, you have to tell them what Dr. Bhandari said, the minimum possible things. It is not that what Dr. Segedar said, that bacteria are less here, bacteria are more there. It's not so. Court wants minimum criteria by which the person can operate in the operation theatre. If you go ideally and all the norms of the RTO has to be followed, not a single car there will be on the road. So ideally, for academic purpose, we can discuss ideal one, but for practical purposes, the basic minimum requirements has to be enumerated, and that should be supported by the MOA.
Thank you, Narayan. That's what I wanted to say.
Yeah, Dr. Karne, we will keep it in mind that to have a medical legal aspect of a small hospital and an ideal hospital.
Yes,
thank you, sir.
We write a chapter on
Thank
this.
you, sir. Thank you.
On mind. Yes, thank you.
Thank you. Can I go ahead, sir?
Yes, yes.
Yeah.
Okay. So at the outset, let me thank Dr. Gadegone for insisting that I talk in this webinar, as well as the MOA for giving me this opportunity. And I know that in this stalwarts meeting, I'm the only one who does not own an hospital or who has never built a hospital in his life or an operation room. But fortunately or unfortunately, I have operated in most of the people's hospitals who are there on this panel. And I will share my experiences. My scope of work as Professor of Orthopaedic Institute, visiting specialist at Bharati Vidyapit Medical College, allows me to look at pediatric orthopedic surgery and orthopedic surgery in different settings. Also, I have been operating for the last 20 years in Dr. Kakatkar's hospital, Dr. Pati's hospital, and even Dr. Deshpande's hospital in Ahmadnagar. And I have seen the evolution of the peripheral hospitals from what was there to what is ideal, as Dr. Kulkarni said. I will talk about the human aspect. Everybody has spoken about the technology and the ideal methodology. But I think the God in the temple here is the patient, and the surgeon is actually the pujari in this temple. So our job is to make sure that what we are trying to achieve, we cannot be the victim of our environment. We have to create favorable condition, and it is our inherent driving force and energy to make things turn out as we desire. So what happens inside the operation theater is like doing puja, where we need a clean, sterile environment for one, isolation of the patient, for safety, to prevent complications, especially the dreaded complication of infection, and anesthesia complications, so that things are under optimal control for surgery and anesthesia. And the third, if you recollect historically what Sushrut said, the operation theater name comes from theater because it was meant for teaching and training, which is an integral part of an operating theater in institutes. The aim of the operation theater, I believe, is the 4 R's for orthopedics. You repair, or you reconstruct, or you replace, or you restore function. So our job is to create a milieu exterior for optimal efficiency and safety for all those who are involved. When you talk about personnel and staffing, it has to vary from place to place. So optimal staffing for a private institute versus a teaching institute versus an urban nursing home versus a rural nursing home may be totally different. But as mentioned earlier, crowding in the OT is not desirable. Staffing is a selection, training, and motivation and retention of people in the organization. So the measurement of this can be by the population ratio, fixed requirements, number of hours involved, and hours with patient care, and how much is your workload. How many cases do you do every day? How many hours are spent in the operating room? What is the type of cases that are you doing? What is the nature of your cases? And what are your guidelines, norms, policies, and procedures given by authorities? So all this will decide how many people are you going to employ and what is their role going to be. But the benefits of good staffing are the improved patient outcome, lower mortality rate, increase efficiency, reduce your patient waiting time for surgery, and balance the workload. The primary aim for an efficient surgery has to be teamwork. So I have put into white the minimum requirement, as Dr. Phadake was insisting. The surgeon who has a first assistant, preferably one anesthetist, one scrub nurse, one circulating nurse, one radiology technician, and one ward boy. What I've mentioned in yellow, +1, +2, +1, and a surgical team of fellows, residents, and observers are excess or superfluous requirements which may vary from where you are operating. The critical steps for success are pre-planning is how you get the OT ready first. Your OT has to be mopped with clean floor and a white table, a trolley which has been laid out freshly, an pre-anesthetized patient which is wheeled in so that there is no confusion. You prep, drape adequately and do your surgery cleanly. And I believe that infection also happens because of prolonged closure times. In institute, a lot of time is spent in closing the wounds. The primary surgeon goes away, and especially for spine and long surgeries like tumor surgeries, if the primary surgeon isn't around, then the delayed closure can also expose the wound and make it susceptible to infection. The second important thing is the turnaround time, which Dr. Gadegone said there will be a separate talk on it, and how do you take aftercare in your recovery room. But please believe me that the buck stops with the surgeon. All success begins with self-discipline. It starts with you. The surgeon must give clear instructions to the patient as to what is that he should expect in the operation theatre, so that he is prepared mentally on how to behave. We should not have a screaming, fighting patient in the theatre which can generate more bacteria. We should have an anesthetist who is clearly told what sort of anesthesia we expect. All the staff should absolutely know their roles, and the assistant should be prepared so that there is no unfavorable outcome. These are typically how institutional lists look like. There is a list of cases, but what is more important is to put them in order. Which theatre, which case is going to be done, who's going to do it, what is the requirement. In a private setup which is corporate, people come and book their cases and go away. So there is no central control. And people don't know when it will be available, whether it's clean when they go in the theatre. Whereas in a situation like this, where there are multiple theatres in a private nursing home or an institute like this, more than one theatre, organizing a list becomes the first step in preventing complications. And while I scrub up, I can always have two cases lined up in one theatre and the second theatre so that time wastage is avoided, turnaround time is less. And I know exactly how much time I'm going to take in one surgery so that I can move on to the next one. So once you work out your plan, then you proceed to implement it with the optimal person. This is the minimum required people in the room, as I'm showing you: the primary surgeon, the scrub nurse, the first assistant, the ward boy, and the C-arm technician. Obviously, the anesthetist is at the head end. Please control the crowds in your theater. This is an example of what should not happen. There are about 13 people in this room, which is a medical college, and there is a lot of confusion and unnecessary thoroughfare and traffic in the theater. The role of the first assistant is plan for the surgery, make sure that the implant and fitness is available, the blood requirements are met, special equipment is available, actual assistance during surgery, especially a quick closure, and he should transfer the patient with handover to the recovery physician. The anesthetist should be clear about what pre-op medication he needs to give and must consult with relatives. A lot of times, the anesthetists don't talk to the relative pre-op and they are not aware of what is being done to their patient or the child. It is the anesthetist's responsibility to do timeout. Make sure that the timeout is done and all the surgical checklists are checked. Giving anesthesia, maintaining it are critical steps. And as Dr. Kulkarni pointed out, preferably lock the room so that they cannot leave for their coffee breaks or WhatsApp breaks. They should document the type of anesthesia, because medical legally, as Dr. Karne has been repeatedly saying, if we don't have documentation, we will be in trouble. They should be responsible for post-op analgesia and should give post-op instructions to the patient regarding nil by mouth, because that is the first question that will be asked in the recovery: when can they have food? And you have to tell them, the anesthetist will instruct you accordingly. But please remember, don't fight with your anesthetist, because in case of a critical complication, he is the only qualified person in the theater to save a life, right? Arrest, bleeding, embolism, your best friend is your anesthetist, so keep him close to your heart. The scrub nurse, the trolley setup, the cautery and suction arrangement, the C-arm, draping, the mop and gauze count, shifting of the patient and preparation for the next case is their duty. The circulating nurse is extremely important. The job is to help the scrub nurse in all aspects. She has access to all extra trays, drains, suture materials, gloves. So she cannot go out of the theater. Accessing special requirements, gel foam, bone max, bank grafts, adjusting the table lights, seats, coordinating with the OT store, and coordinating with the recovery staff regarding when the patient is going to come out. So she helps you prepare for the next case. So it is very important to have one free person in the OT other than your scrub nurse. The OT attendant, also called as ward boy, I am very critical about their attire and attitude. The attire, because half the nursing homes, especially in small nursing homes, will have maushis who will come with a lot of jewelry on them. When there is jewelry on them, that is a source for bringing in infection. So it's important that you should have a proper attire and a protocol as to what clothes and what dress should be worn in the theater. Most of the ward boys are walking around with their tops outside and not in, and they are everywhere. So that is not acceptable. So it's your job that you make your staff oriented to what is going to happen. And I have listed down the list of things that the OT attendant needs to do. The CM technician should know about imaging, handling and troubleshooting the equipment available to you, cleaning and safety protocols of the radiology unit that you have, printing the attached reports to the file, and providing protective equipment for all in the theater. The CSSD has been spoken about. These are extremely critical members, though not in the direct vision in the OT. You need efficient and honest methods. Equipment handling, storage, and disbursement is what is critical, and how you pack them and how you bring them is equally important. Finally, education is a responsibility which needs to be done, but not at the cost of patient care. So you must be judicious in how many people you let into your theater so that you don't have an overcrowding or traffic. Small team, the primary surgeon has to be the king there. As a visiting surgeon, I go there, but unless the owner of the place is in the OT, the system doesn't work. So it should not be that if the visiting surgeon is there, the primary surgeon is going out and doing something when the case is starting, because the system doesn't respond to the visiting surgeon. The anesthetist is usually the assistant cum radiology technician. So he is also showing the serum. And that is usually one multi-purpose worker assistant, right, who is doing everything. Now, if you do not insist on their proper attire and their discipline and their hygiene and the way they conduct themselves, then you will have infection. Dr. Bhandari, what he says is right. Financially, you cannot reproduce an institute in a small nursing home, but you can enforce discipline. And that comes from the owner of the hospital. I have had situations where I've gone to operate where the relatives of the surgeons are walking in the OT just because they want to see an operation without wearing cap or mask. So that should not happen. The discipline of the owner is very, very important. The team outside is also extremely important, because half the time in periphery, the generator conks off, the electrician is not available, the diesel is over. You need a driver who can run around, get an implant which is not available from your colleague. Controlling the crowd outside the theater is a big issue. In and out, both is a problem. And please have a good rapport with your colleagues, because in times of crisis, they can lend you equipment which is autoclaved, like drills, implants, and save you from a crisis point. So discipline, I think is extremely important from the primary surgeon who is handling the case. I believe any surgery that lasts more than 1.5 to 2 hours has higher chance of infection, especially complex compound injuries, and any surgery which involves advanced interventional equipment like implants in the spine or arthroscopy or replacements. And any theater where there is no discipline, it doesn't matter whether it's corporate or small. So to remind you again, the OT is a temple. You are the pujari in the service of the God who is your patient, and always try to give 100% at your job. Thank you very much.
Thank you, Sandeep. I think what you said is the most important thing. You are the captain of the ship in a small setup. And if you are disciplined, the whole staff will be disciplined.
I think Sandeep, you are very practical tips to the all the small setup surgeons.
because he has gone to many hospitals and worked as a visiting surgeon and probably has seen all different type of things.
With experience, you understand, sir, where the flaws are. I have seen that the smaller setups can have 0% infection rate provided the surgeon is meticulous in every small detail.
That's what I'm saying.
I've seen the evolution of theaters over 20 years to what is at par with institutes. So it is not that the periphery is what it used to be, sir. In periphery today, joint replacements are done.
Yeah.
Sandeep, when you write a chapter, you also write the prime duties of a particular staff member.
Yes, sir. I've put that down. We'll elaborate on that.
Okay, sir. Sir, Agashe, sir, please go ahead.
Yeah. Thank you, Sandeep, for a very enlightening talk. Prophylactic antibiotics, especially the duration of prophylactic antibiotic, is a hotly debated topic. Before I start, I thank Dr. Gadegone as well as MOA and allowing us to talk on this hotly debated topic. Initially, I would be discussing some basics, and then we will open it as a debate between myself and Dr. Aditya Menon, who is my colleague. So what is the basic as related to surgery? As soon as you take an incision, the surgical field is flooded with bacteria or microbes which are in planktonic form. They keep moving and moving as a single cell. Can you mute yourself, please? So they keep moving as a single cell. Within no time, they are taken up or destroyed or killed by antibiotics as well as body's defense mechanism. But if the situation is favorable to bacteria, some of them succeed to attach to the implant or surgical site, and then they start getting connected or attached to each other, and then start recruiting more and more planktonic bacteria. The body tries to prevent this by forming a membrane to prevent this bacterial invasion. Bacteria also try to attack that, and then there is a competition between body and these microbes, what is called race for surface. When there is the tissues are traumatized and avascular, or the body defenses are poor, then bacteria secrete extracellular matrix and then get embedded into that, and the biofilm formation starts. Now this colony starts getting established. The requirements decrease, metabolism decreases, inflammatory markers reduce, the bacteria develop, or these biofilms develop pathways for nutrition. They arrange themselves in 3 layers: the superficial, which has highest oxygen; the second layer, which is down regulate the metabolic activity; and the last and most important, the deepest layer, is what is called persister cells, and they are dormant. They are least metabolically active, and they're just unresponsive to any antibiotic. They are not necessarily resistant, but they just respond, don't care about the antibiotics. And there is something which we have realized now, and that is quorum sensing. And that is act of communication between the microbes, and therefore they don't behave like a single cell, but behave as a multicellular organism, and then they decide at what time they will burst, what time they will not burst, and therefore they will decide whether to disperse themselves and cause distant infection. Now, as this starts, generally there is ESR CRP, maybe normal culture will not grow. The leukocytes get frustrated, and then they start going underneath the implant and cause weakening or loosening of the implant, and then the biofilm bursts. With nail, the entire medullary cavity may get infected. And therefore, if you have to salvage infection and cure or suppress infection till fracture union, we need to attack early. Not with empirical antibiotics, which can kill only planktonic bacteria, but with our knife to take away the adherent biofilm and get samples. Then the remaining bacteria get converted into planktonic form, and then the surface may become sterile, and we would be able to salvage salvage the fixation. So friends, the first and foremost thing is avoid biofilm because they are safe, abhorred for bacteria, challenge for surgeon, and disaster for patients. With that, I will start the debate. I believe in maximum safety for my patients, while Aditya would say that here more is less. And therefore, I go with the common Indian thinking. I'll start with at least 2 antibiotics. I'll start 1 day prior and give anything between 5 days to say a couple of weeks till suture removal, because that way I'll be able to prevent infection. While Aditya feels that cephalosporin, first or second generation, maximum for 24 hours and no more. And of course, you all would be referees. So as I said, we must prevent biofilms. Yes, we would give antibiotics, but I would give antibiotic 1 day prior because I would like to kill all the bacteria so that none enters the body. I base my hypothesis on common sense, Indian literature, and we are a democratic country. Majority wins. Aditya, do you have insurance? I'm just talking common sense. You have insurance. Yeah. Why? Because you want to play safe, right?
Correct.
What is your premium? 200 rupees a year?
Much more.
Much more. So why should my patients spend only 400 rupees for prophylactic antibiotic? The cost of first or second generation cephalosporin, just 400 rupees. Why not buy insurance which protects all the suspects? Because my patient is affording. So why should he not spend adequate money? I would like to prevent all these bacteria entering my surgical site. So I will kill all these bugs. I'll give antibiotic prior and kill all these bugs before they enter my battlefield. So when they enter my battlefield, I will continue to give my antibiotics till even a single remaining bacteria is killed. And to make myself sure, I'll just continue giving antibiotics so that there would be no bacterial invasion of my surgical site. Now you would say that this will increase the resistance globally. I'm more worried about my local things. I'm more worried about my patient. So coming to local things, this is a ISEO article. Have you heard of ISEO, Aditya? Indian Journal of Orthopaedics. Have you heard of that?
Yes, sir.
Okay. This is our journal. They say that internationally 1 to 3 doses of first generation or second generation cephalosporin and nothing beyond 24 hours and oral. This is all fine. But in our country, now this is an editorial in ISEO. In our country, theater conditions and prevalent pathogens are different. Our population has different socio-economic background, and we cannot compare ourselves with developed Western world. So here we require large multicentric indigenous studies in our country, and we need to have level 1 studies to formulate guidelines. Do you have anything like this? I don't think so. Last but not the least, democracy. We are not in a dictatorial country. So in past 2 years, I have conducted several surveys of more than 600 orthopedic surgeons. Duration of prophylactic antibiotic, more than 50% people said till suture removal. So why don't I follow democracy? 75% people give oral antibiotics after injectable antibiotics. Why shouldn't I follow that? And many of them follow various antibiotics, but yes, many of them follow first or second generation for 3 days, but most follow oral antibiotics for at least 5 days or till suture removal. So there is a clear mandate for giving antibiotics for about 5 to 10 days. So from all these, common sense, editorial of ISAO, and clear democratic mandate, I feel that we should start antibiotic 1 day prior and continue it till at least 5 to 7 days or probably till suture removal. Aditya, stage is yours.
Thank you, sir. I'll try and have a comeback to your excellent talk on why is it difficult to implement these international guidelines in our local scenario. So I'll start by summarizing your talk, sir. What you have emphasized and focused on is we must give a combination of high-end antibiotics, start 1 day prior, continue for more than 24 hours, maybe up to suture removal. We lack good Indian studies, and it's a democracy. I'm sorry, sir. I've been a student for a long time. I've learned a lot of things from you, but chota muh badi baat, but I think you're thoroughly confused. I'll ask you one simple question. Why do we give prophylaxis? Why do we give those antibiotics? It is for protection against predictable organisms. And which are those predictable organisms? This is not what is coming out of my mind. This is what is given in our books, in literature. The skin organisms are the predictable organisms. And which are those? They are staphylococci and coagulase negative staphylococci. They form 98% of the predictable organisms. And which are the antibiotics which are best for these? They are first and second generation cephalosporins. Again, this is there in Indian textbooks also, apart from international textbooks and literature. Your question, why not cover for gram negative? I will answer this question, sir, with a paper which is from our own country. I hope you've heard an institute called AIMS.
Yes,
it is not just a local institute, sir. It is an internationally acclaimed institute. They did a study of 237 patients who underwent revision surgery for suspected infected or aseptic loosening, of which 45% met the definitive diagnosis of periprosthetic joint infection, and they could isolate 92 organisms from that. The commonest isolate was Staphylococcus individually, but if you looked at it as clubs of groups of gram negative and gram positive, gram negative are more common overall. So here they agree with you, sir, that gram negative are more common. But they went ahead and they analyzed the antibiotic sensitivity of these gram negative organisms. And not surprisingly, which we are seeing every day, there is vast increase in resistance. There are only 30% sensitivity to amikacin, 20% to third generation cephalosporins, piperacillin tazobactam only 40% more. With piperacillin, even meropenem had only 50% sensitivity. So what they emphasized, our local study emphasized, was gram negative are not colonizing flora. They are fallout of poor infection control practices in our operation theater. And there are no foolproof antibiotic options available because even meropenem will work only on one out of those two bacteria. So what are we going to give? There is nothing predictable. The flora is varied, the bacteriology is varied, the antibiotic sensitivity is very varied. What will happen with increased use of higher antibiotics? There will be no added benefits because they will not work on half the antibiotics. They will only increase resistance. So, sir, your expensive antibiotics will not protect against these infections, no matter what. Now, coming to your point of starting antibiotics 1 day prior and continuing for longer. Now, let us look at this graphic where we give antibiotics half an hour prior to this incision. The idea is it collects along your surgical area and has maximum concentration. Once we take the incision, the skin commensal always enter the area. That is why the antibiotic is given. This antibiotic then kills those organisms, and when we close the wound, there is no access for these bacteria to again enter. So giving prolonged antibiotics or more than one dose beyond 24 hours has no logic because the skin is sealed. Bacteria are not entering it again. Now, what will happen if we start 1 day prior, earlier? that would do what? It will kill all the sensitive organisms. Because as we've seen from the study, there will always be resistant organisms. In this animation, the red circles are the resistant organisms. No matter which antibiotic you give, some bacteria, especially resistant bacteria, will survive. They will multiply because we are giving them enough time to multiply before our surgical incision, since we started antibiotics 24 hours prior. We give our prophylactic antibiotics in the OT, but they will not act because these organisms are already resistant to the antibiotics we've given. No matter how many doses, 2, 3, 5, 20, 40, they will keep continuing because there can never be a bacteriological vacuum. And this has been established in multiple papers which show that if the antibiotics are given 2 hours before or 3 hours after the incision, chance of infection is at least 6 times higher. Now, coming to the slide that you have shown, sir, from the survey across various orthopedic surgeons who have predominantly highlighted poor hygiene, I want to play safe, and I'm not sure of the OT setup. What does this show, sir? It shows that it is not staph aureus that is the problem. It is staph aureus. It is our duty, it is my duty, your duty, all our duties to improve the OT setup, train the staff, and not give antibiotics worth thousands of rupees. And that is exactly why our Honorary President Gadegone sir has initiated this unique and very important webinar on OT is my temple. And that is what all the stalwarts have been emphasizing on. Yes, there is a minimum, but we must try and follow ideal. And my talk says something very simple. This webinar is focused on small to medium setups, but this concept applies to small to big setups, because small antibiotics was small, use smaller duration because that is better. Bigger does not mean better. Finally, you would say, what if my patient gets infected? Only antibiotics will help. There we must continue antibiotics for a longer time. But sir, this is something that I've learned from you. There is enough literature which shows that once an implant gets infected, we have maximum 4 or 6 weeks to do something to salvage that infection. Because the idea is we want to salvage that infection and not go into an infected non-union. What will happen if we give empirical antibiotics? And these are slides which you've shared. The empirical antibiotics will only kill the free-floating planktonic bacteria. The biofilm does not get affected. The only way to get rid of that biofilm is to go in surgically with our knife, excise that, debride, get a clean bed, and then our targeted antibiotics will act on the remaining bacteria and we can salvage our fixation. So prolonged antibiotics is only going to suppress the infection, and eventually the patient will come back to us or go to some other surgeon with a frankly infected non-union, and the biofilms will be across the fracture site along the medullary canals, and no amount of salvage will help. Then we will have to go for an implant removal with stage surgeries. As far as democracy is concerned, so we are at a war. We are at a war with multiple microorganisms. I don't think Field Marshal Manekshaw ever asked for a vote. To drive home what I have been saying for the last 5 minutes, I take all of us back to Hinduja Hospital 15 years back, where a study was conducted by the infectious disease and the medicine team along with the microbiology team. They assessed the antibiotic protocol given by various surgeons, and even at Hinduja 15 years back, multiple antibiotics were given for multiple days after surgery. Now, all of these patients were followed up. These were clean cases. None of them were infected cases. All these clean surgeries were followed up for 1 year, and the infection rates were assessed. Cardiac surgery patients had maximum infection rates in spite of giving antibiotics for more than 10 days. And the overall conclusion of the study was infection rates were higher in those patients who were given higher and prolonged antibiotics. So again, higher does not mean better. Remember, small antibiotics, smaller classes, smaller cost, smaller duration is always better. So let's stop this drama, because I know this study has also convinced you to believe in lesser is better. You've initiated this at Hinduja and taken this to your own hospital, where you follow this protocol of 3 doses of first and second dose cephalosporins. So if you could come in here and give your final take on this debate.
So friends, this was just a drama we played. I represented a common Indian orthopedic surgeon. However, I am thoroughly convinced that there is no point in continuing antibiotics beyond 24 hours. Aditya, yes, you win, because for last maybe 12 or 14 years, even in my small setup of 10 beds, I have been following this protocol of giving first or second generation cephalosporin for not more than 24 hours. And I sincerely feel that we should all follow that, irrespective of the size of nursing home. The most important thing that is needed is what initiative Dr. Gadegone has taken, improve our OT setup and train our staff and train ourselves. Thank you, friends.
Thank you, sir.
Thank you.
Vikas, it was really good. We learned a lot. Nice organization of this seminar. Thank you very much. I thank Dr. Gadegone and Dr. Karne for making me a part of this seminar. Thank you very much. Enjoyed it.
Dr. Bagli, we still have one more talk.
But I have some other commitments.
Okay.
Thank you so much.
Thank you, Nitin. Thank you, Nitin.
Thank you. Thank you so much.
So, actually, we'll complete the talk of Pahukar, and then we'll discuss among ourselves regarding all topics. Okay, sir?
Sure.
Okay. So, go ahead, Pahukar.
So now, very good afternoon to all of you again. First of all, I would like to thank MOA for giving me this opportunity. And I think we certainly have a very good session till now on various aspects of various things which we install, do, or prepare or plan in the OT. But all these theoretical topics will not be helpful if we apply them practically. So it is very good to have some kind of OT checklist always, which has been emphasized by Dr. GSK sir as well as Dr. Patwardhan, before you enter the OT. So a surgeon is a multitasker person, basically. He doesn't only see the OT. He tries to have so many things at his hand, the OPD, wards. He is too much busy to plan that surgery properly. And I think every surgeon must have felt at certain point of time, repented that some intraoperative complication has happened, and he could have avoided if he have taken some good precaution step before, so that this prevention is certainly possible of all these OT complications which happens. So we always follow some kind of checklist for our own most of the daily activities. So why not to have something for the OT checklist? I know it is quite exhaustive. It's usually a team approach. Everybody needs to be involved, right from the OT technicians, the nursing staff in the ward, the CSSD personnel. But I think that should be having some kind of protocolized thing for all these things to be happening. Even WHO has recommended it very honestly to follow this preoperative checklist to prevent any complications. And even very well, this Dr. Atul Gawande has one of his books on this checklist manifesto, so as to how to get things right. So just to make your, you should have this pre-op OT checklist. You need to just check the boxes before you enter into the OT. So this is what we have devised. This was like, I had devised this into the three categories: a single page surgical checklist for orthopedic surgeons before they enter OT. If they have a glance of all these things just before entering, around only for 30 seconds or a minute, they would certainly prevent few of the things or unhappenings which sometimes happen, which we know, but sometimes because of lack of time or lack of planning, we don't implement. So I had divided into the three categories, like the patient related categories, the operation theater related categories, and third are the surgeon or procedure related categories. We'll go one by one to see all of them. First and foremost are the patient related, the correct patient selection. Always have ID badges. This is very crucial. Like in our time checkouts, we do have this coding, like that particular patient will have some UHIC code, and which needs to be uttered and checked on the patient's ID. So this is the first step. Second, always we know the correct site, but what we don't know is the correct site marking. This has been also beneficially improved. Like the OT personnel will know that where the surgeon will be able to take the incision. Accordingly, he will try to prepare or drape for that. Even the patient will understand that this kind of incision I will be having in the surgery. So I think this site marking is as equally as important with this site as well. we know all this about informed consents. I certainly agree, but there are certain consents from orthopedic surgery that we usually underestimate, like the bone grafting consent. We usually doesn't mention it as a separately that he will have a separate incision. So make it very precise. That's a iliac bone where we're getting another incision to take out the bone. The another, sometimes we need the vac dressing, the other grafting, these procedures also needs to be mentioned. Another thing, along with Dr. Chandak, I think we do have these ISOs, the inevitable second orthopedic surgery, where the stage procedures are there. So we need to mention this in the consent itself. This would be the only first procedure. So taking these orthopedic consents in the first hand will certainly prevent many medical legal implications. Another important is to give the good surgery name or the alternative procedure if needed. Like sometimes we use the right hip DHS, that's all. But certainly we are in the OT with all the armamentarium. Sometimes we go for PFN, we go additional trochanteric plate. So what is your actual plan? That should be briefly and concisely, all the OT personnel should be made aware of. Like I would be initially trying to get a reduction DHS, PFN, PFNA, or you can concisely write the hip fixation and here all armamentarium. Sometimes we convert this fracture neck femurs into a hemi replacement. So also that needs to be documented well, because we do have all these plans in hand. Another very important things to know before entering the OT, properly taken the NBM status, weight, which we usually don't calculate, so as the obesity related problems. Again, this pre-operative planning, the beta scrub bath usually, which I give a priority, local betadine painting, all the sensitivity testing. A properly done PSC is very essential before the patient entering into the OT, because sometimes we see many patients having multiple spinal injections because of some deformity in the lumbar spine, which we certainly don't anticipate pre-operatively. Sometimes you can have this pre-operative LS spine X-rays, then the history of any anticoagulants, or if you are facing any special intubation problems like in ankylosing spondylitis. The screening of all these three are now mandatory, not only HIV, HBCG, but HCV is also nowadays made mandatory. Another thing which we miss sometimes is to screen for the DVT for the high-risk patients. And we doesn't usually neglect this thing. But preoperatively screening, checking the pulses is also very important. Another important thing is to get a patient as a global status of patients. We just try to start operating, but you need to understand the diabetic status, whether he is under control or not. HbA1c is one of the important indicators if you are going for a planned surgery. Urine routine, sometimes we missed out. Sometimes it is better to have urine culture as well, where you are going for any prosthetic replacements. MRSA screening again is very important. I think has already been highlighted. Then whether the patient is on for rheumatoid having various steroid or DMARD uses needs to be mentioned. The another two aspects are the osteoporosis and obesity. These two things we need to consider while starting the operation. Another very important to look for any drug or any other toxicities or allergies which the patient have. Another is to have the personal hygiene and skill problem. So sometimes we start operation, we doesn't see the local part. He could have fungal infection over there. So pre-operatively screening those parts by somebody will prevent many problems. Another pre-operatively patient-related factor is to discuss the expenses very well. Sometimes we change our operation theater procedure to something else, and we doesn't consider the additional cost which patient needs to be incurred if we are going for that additional procedure. So these things should be explained very well before undergoing that particular surgery. The second line of is the theater related problem. I think these all things have already been talked very well about the OT lights, temperature, the availability of pulse oximeter, suctions, cautery pad which is attached safely, various tourniquet sizes. Important thing is to have the how many number of persons you are going to keep in the OT. For a CM technician, one assistant, on how many on the anesthetist. You need to maintain that traffic and try to follow those protocols for that particular surgery. Another important to have a good fracture table attachment, the TLD batches. You should have a very good person who could able to show you this CM images properly. A trained technician will be very helpful. You need to see these fluoro images sometimes to stability of that particular implant. The autoclaving, as already discussed, one important thing which we usually miss, that sometimes we incur some infection and repeated infection. Then we see whether we are doing autoclaving correctly or not. So I think this point has been missed. These biochemical and biological indicators, class 4, which are very routinely used, needs to be checked by surgeons at least a weekly or monthly. So this is another important aspect to check pre-op to prevent infection and whether all your sterility is properly maintained. Another important to have a good power backup while you are performing an OT. Police catheterization, again, we just sometimes forget. We sometimes do it pre-operatively, sometimes post-operatively. You need to have that protocol pre-operatively, just after induction with some kind of enzymatic. So you should follow that particular protocol always. Another important to have this procedure specific consumable and implants, like you do have shoulder arthroscopy, you should have a shoulder drape. So all these small things will certainly make a difference. Another the point which I wanted to make, we should have a hospital specific antibiotic policies. I think we'll discuss this later with Dr. Agashe sir. You need to have some cocktails for infiltration ready. Sometimes that things dexamethasone or whatever additional things which you want to put in the antibiotic are not available. Anesthesia trolley needs to be checked thoroughly. Emergency drugs are there. The oxygen cylinders, a defibrillator. These are all mandatory things which must be available before you start the OT. For orthopedic surgeons, you need to have this sometimes this suture material which can be handy in various surgeries like ethibonds. For spine surgery, this 40 sutures, then fiber wires, the ab gel, bone wax. These are all common inventory for all orthopedic surgeries one need to have. Another important is to have cement, bone cement in fridge available, which could be used for certain situations. The stimulant beads, sometimes one would neglect this kind of antibiotic beads, tranexamic acid. So you need to be prepared for cementing related complications as well if you are planning for those things. The third and last will be the surgeon or procedure related things. Apart from your IV line securing and properly functioning, the timeout procedure, I think this is a very important. Here we follow that the nurse starts with all activities to be suspended. The surgeon and the anesthetist are available on the table. They listen to whatever this timeout procedure things which she is about to recite. Everybody has to confirm, and then only you need to take the incision. So this timeout procedure will certainly save some problems which could happen later on. Another important is to have the relevant X-ray films, one joint above or below, where you sometimes only have one X-ray film, and then you need to see whether there is any other additional fracture, other injuries. You need to all MRI, CT reports with you, all previous biopsy. So nowadays the operation theaters are with these monitors where all the patient records are available electronically inside the operation theater. This chart usually we do have in our OT, like we need to mention all these hemoglobin, the creatinine, sugar, so that a simple glance before starting the surgery by a surgeon will certainly make a lot of difference, even the blood group. You need to understand the give expected operative time. Just don't write the 8 a.m. I will start with this knee replacement surgery. It is the 8 to 11 a.m. This is the 3 hours duration which I want for that particular OT, and the various steps which I am going to follow needs to be anticipated and conveyed to the OT team. I will not speak much because templating in orthopedic practice is very essential. Important is to mark your pulses pre-operatively. Just mark those pre-operatively and check again post-operatively whether those are present or not. Sometimes this could happen, the dorsalis pedis is not absent, or previous some vascular injuries which could be missed. So again, make a habit of your assistant to check these things, neurological as well as the these vascular pulses properly before you start your surgery. You need to also anticipate whether if some problem will happen during this surgery, whether this construct is going to fail or not, and I am prepared for those complications or not. So this additional inventory or instrument which are available should be made think of. Another is to like we usually do some surgery and then we say to our assistant, ye aaj cheez nahi thi, we need into the next surgery, and we just forget all those things. So the previous difficulty which you have faced in your the similar case, you need to think of. The same experience should not happen. So you should have that procedure specific instruments and problems you can anticipate beforehand and could solve them in the next case. Another important to have some intraoperative complication or surgery which sometimes could happen. So whether those additional extra long stem implants, any iatrogenic fractures which are happening, we are anticipating that surgery are available or not. As Dr. G.S.K. sir are saying that this flash sterilization is not a good thing. So this will certainly add more to our time. So this second line of things which we sometimes need should be made available. The important point is to have a rescue friend, whether it's any additional orthopedic surgeon, plastic surgeon, or a vascular surgeon, which needs to be in hand at a reasonable distance with the calling immediately he could help, because those people will certainly help in some of the bad situation where some complication could happen. We need to have some emergency drum and external anesthetic always available before going for any major procedure. Drilling systems needs to be battery charged. Always I make it a practice. Sometimes this doesn't happen. At least have a one-man drill or a hand drill easily available sometimes if all these electronic gadgets fail. And lastly, this I think has made a slide that all orthopedic surgeries, we need various things on table. Sometimes even we don't anticipate. Like you need to have a good plier, jumbo cutter, one-man drill as a backup, various sizes of K-wires, drill bit sets, even sometimes diamond tip so as to cut some screw. The CC screw sets, I think has been, we can use those 4 mm, 6.5 mm in various kind of surgeries. Then Herbert screws we usually miss out. Then sometimes we thought if this would have been available, the things would have been simpler. The suture anchors, some avulsions, sometimes even in the trauma surgery. The cannulated reamer or the saw set, various circlage wires, the SS wires, cables, pliers, sometimes the burrs or the broken screw removal set. So all these must have sometimes which you need in this operation theater setup. So I think it really makes a difference if you have this single one flyer chart in your OPD desk or just somewhere in your surgeon's lounge in the OT, so as to you just check those boxes, and we'll certainly point out that, yeah, I think I missed that point, and that will certainly give a different insight and could change your plan for surgery, and you could additionally go for that before you make that incision. So I thank you very much again for your patient listening, and thank you for giving me this opportunity. Thank you, team MOA.
Thank you very much, Manoj.
Because one more thing, in line with what Dr. Pahukar has presented, maybe it is more for the orthopedic surgeons. I have got a pre-operative checklist for my staff members whenever the patient is admitted. I'd like to share that. Only one page.
Sure.
Sir, in your lecture also, Bhandari sir, next webinar it is yours.
It is in line with that. My lecture
Okay. नहीं, अभी तक करो, लेकिन in that webinar also you show.
Okay.
Next time your turn is there.
Yeah, sir. One second, I'll just share.
Share it comfortably. By that time we can have questions also.
Yeah, you can have question.
Chandak sir,
may I ask one question, please?
Chandak sir.
Yes, sir.
You with so many accessories, and sometimes it requires in emergency accessories, it is lying in the cupboard or in a room for a very long time. And in such a situation, how to at least disinfect that article?
Yeah, the best is alcohol spray. For an accessory which is brought out from outside of the theater, the best is to use an alcohol spray, and these alcohol sprays are available. They are instantly effective.
What about burning?
No, he is asking about a equipment or a accessory of a table which is brought out from the outside.
Accessory of a table. And if suppose some instrument.
And what you are asking is, if an instrument falls accidentally, and it is essential to use it again.
And there is no flash sterilizer.
So then there is a 3-step method. One is a Sidex dip, and then on the trolley 10% betadine dip, and then you can use it with some reservations. It is not an implantable device, but you can use that implant instrument only if you need it so urgently and so necessary.
What about burning in spirit?
So if you are desperate to save the life of the patient, then maybe this is justified.
Yes.
But otherwise, best way is to wait till it gets autoclaved.
Right.
And second thing I want to ask, whether day before enema is necessary. We are not giving, but academic discussion. Enema before
we can give clemafin or something 1 or 2 days prior.
Sir, I think that is a spillover from the ancient days of general surgery, where general surgeons used to evacuate bowel for clean, efficient bowel surgery without contamination of the peritoneal cavity. So and it is just blindly handed down, and it really is not relevant to orthopedics.
Very.
Okay, so this is what I had prepared for my staff members whenever the patient is admitted for surgery, because we have discussed what a surgeon, but many times you may not be able to really remember everything, or your staff may not be able to remember. So you attach this type of a checklist to your patient's IPD paper, and then you mark what you want on the left side, the doctor checklist. You want these things. And as they go on doing this, like even deciding the time of the surgery, taking the time of the, especially for small or medium sized nursing home, this type of checklist can help the staff, and you are also comfortable because all things are done. And just before you enter the operation theater, you see that all the boxes on right by the sister are checked in. What you have checked on right, left, they have checked it on right, so that there will not be surprises in the operation theater.
Perfect.
Bhandari sir, you can do one thing. You just give us a printed copy of 2000. I assure you, it will be posted to all orthopedic surgeons.
Yeah,
sir. No, you don't sir, just a comment here. Sir, just a comment here. The checklist has to be customized to the requirement of the individual place. It cannot be Dr. Bhandari's checklist for me.
Correct.
So what we are agreeing upon as a consensus statement is that everybody must have a checklist. But you have to create your own checklist. You can use different guidelines.
Yeah, sir. This is just a model.
You mail a soft copy to everyone, and they can modify it as per their requirement and get it.
Exactly.
But this is very, very useful.
It's a concept.
Very useful.
So stop sharing and then we'll discuss.
Yeah. Question on the last lecture on Dr. Agashe sir's presentation. Sir, we use prophylactic antibiotics. Do we need to rotate our prophylactic antibiotic, or it can be universally one throughout the year?
So generally, major hospitals have their infection control committee, which would consist of microbiologist, the ID specialist, and so on and so forth. They go through infection rates and the type of organisms of last 1 year, and then make suggestions as per the what prophylactic antibiotics to be given. Based on the routine culture pattern, based on common complications of these commonly used antibiotics and the community acquired infections, they would suggest what prophylactic antibiotic would be best. Based on these studies, the prophylactic antibiotic may be rotated or changed, but otherwise, at least at Hinduja where we work, the prophylactic antibiotic suggestions have remained same over last 10 years.
Okay.
Sandeep, you have to...
as long as your resident flora doesn't change drastically, major changes are not required. And that comes with the infection control committee, as you rightly pointed out, and frequently establishing who is your colony, which is resident in your theater. And then you decide. Usually it doesn't change. So unless you move from there to an ICU setup, because I've always found NICUs will throw gram negatives. So the population of gram negatives is more in NICU in prematures. When we drain septic arthritis of the hip, we always find Klebsiella, whereas it's otherwise staph outside.
So what you are talking of, let me just interrupt. What you are talking of is how you decide empirical antibiotics when there is already an infection until the time you get your culture sensitivity studies. Now that is a different ball game, as you rightly pointed out. As regards prophylactic antibiotics, it is decided by ID specialists.
Yeah, and your hospital flora.
Your hospital flora.
And most practically, it would be cefazolin or cefuroxime.
Correct. Cefuroxime. That's what I'm saying.
First or second generation.
First or second generation. That's
cefuroxime is the one which I think most commonly used. Cefuroxime.
So the first generation cephalosporin was not available at many places for quite some time because it is very cheap. The pharma companies find it very difficult to actually make two ends meet if they continue to produce first generation cephalosporin. And that is why many have stopped manufacturing that.
Sir, I wanted to make a point that hospital antibiotic policy is usually based on all the literature usually. So they usually quote all the foreign literature. So they wanted to have...
No.
It is again for your hospital.
Yes.
So we'll ask Alok Chandra Agarwal what protocol he uses in AIMS.
In our department of orthopedics, we are using cefuroxime injection just pre-op in the evening and the second day morning. So that is routinely used for non-infected surgeries. For the cases which are infected, we do a culture sensitivity, and based on that, we may continue the antibiotics for 4 to 6 weeks, especially in cases of chronic osteomyelitis.
Any specific reason for using on the pre-evening day?
No, not pre-evening day, so before surgery, in the
Just
evening
before
of the
surgery.
surgery, next day morning.
Okay, three doses.
It should ideally the 1 hour before surgery. Within 1 hour before surgery, I think is the ideal recommendation for the first
Actually,
dose.
there are very differences into it. Half an hour before, just before the tourniquet, 1 hour before. But our anesthetist gives it in the theater after giving anesthesia. That is what we are following. We are happy with that.
Vikas, sir, I would like to ask you about this. How much time before? Because I attended a big conference where they were saying 2 to 2.5 hours before surgery is the ideal time, and they gave a lot of references for that. But usually we follow half to 1 hour prior to, with induction of anesthesia. What we say.
As Dr. Agarwal said, there is a lot of variation, but 2 to 3 hours is stretching it too much.
Okay.
I think about half an hour before incision, and definitely before inflating tourniquet.
Yeah, with induction of anesthesia is what usually, because they put on the IV line. First
They
give
will
an IV antibiotic.
catch the bacteria when they are not suspecting anything. Your antibiotics has to be waiting and kill those bacteria which do not suspect anything.
There is one
One-
logic again.
one-
Sir,
one
there-
important point.
Yes.
Sorry.
Also depends on
Sir, there is one logic again that with the induction, if we give, if there is any reaction of the drug or that, so to prevent that, we give half an hour or 1 hour prior. That is better. So if,
And also
unfortunately,
depends on what antibiotic you are giving. If you are giving vancomycin, maybe it has to be much
More
earlier. But that there are very few hospitals where they give vancomycin because the incidence of MRSA is high.
So, Sir Kulkarni, what is your Kulkarni sir? What is your input?
So Ajay, I was telling the same thing. It depends on the antibiotic used. Vancomycin takes 1 to 2 hours before, and cephalosporin take half an hour to 1 hour before. I was just checking if Vikas told the same thing.
Sorry for interrupting.
I was just adding a point here was that our anesthetist will give a skin test dose at time of induction, so that you have 20 minutes to look at a reaction if it happens. And when the surgeon washes up, you give the antibiotic, so that you are about 10, 15 minutes, 30 minutes prior to when. So that is how we do that.
Prakash, what I was telling is not with the induction of anesthesia. When you put up the IV line, when you put up the IV line before the induction of anesthesia, you give the antibiotic so that there is sufficient time before induction.
Yes. So, Bhandari sir, we are discussing this all in 3 weeks. Next Sunday, 13th and 20th.
Yeah.
And all are invited. And next time in charge is Dr. Gawale sir, Manoj, Pahukar and Chandak sir. Be prepared to be there next Sunday, and we will going to discuss a very good interaction, and all will get linked, those who are in our group. And please start writing. Sigedari is our in charge of this book, and Dr. Chandak sir, myself and Dr. Karne and Dr. Vikas Agashe will assist you, and probably will have to take the help of a senior Kulkarni sir for a final write-up. So thank you very much.
Gadegone sir, one humble appeal to MOA. Do we have an informed consent of every fracture? Suppose, for example, if I am treating a lower end radius fracture, I should be able to tell my patient, or I do tell my patients, that these are the options available, right from K-wires to the plating. And amongst that, the patient had chosen to go for K-wires or X-Pix or cast and pins or a plate. If he is not willing for plating, then he has to specifically and categorically mention that doctor has suggested me to undergo intra-articular reconstruction with a holar plate, dorsal plate, so and so forth. In spite of that, I do not wish to undergo any open surgery, and I am choosing this particular option.
Sir,
Are we going to make a list for all the fractures?
Sir, Dr. Karne is going to talk on this, how to be an ideal consent, and there will be a separate presentation by Dr. Karne on this issue in the last webinar on 20th. So there is no problem about it. We are covering that also.
Thank you, sir.
Gadegone sir, one thing I want to say, as you said, I also am in the process of preparing a poster for the OT staff in a small or medium nursing home.
आप बनाओ लोगों तक पहुंचाने का काम हमारा, क्या करने सर?
पोस्टर करके बाहर लगाना है, मैंने किया था हमारे सिविल हॉस्पिटल में सर, ऐसा करना है, कैप नहीं डाल के जाते हैं, चेंज नहीं करते हैं।
आप 2000 छाप के दो हमको, सबको पहुंचाना हमारा काम।
मैं ऐसा मॉडल भेजूंगा आप।
सर छापने से ज्यादा पहुंचाने को पैसे लगते हैं।
ज्यादा परफेक्ट
गाड़ेगोने सर छापने से ज्यादा पहुंचाने को पैसे लगते हैं।
हम पहुंचा देंगे,
आप मास स्केल पे प्रोडक्शन कीजिए।
Neeraj, I hope you have stopped recording.
Dr. Bhandari. Gadegone sir, any questions on your chat box?
We will talk on that about your checklist and everything and how it will be edited, modified.
Large amount of orthopedic surgeons are doing.
Reach all the orthopedic surgeons, that will do later on. One thing I just wanted to talk about the consent part, that I had given 4 talks up till now on the consent in orthopedics especially, and Indian Orthopedic Association has given me a task or job to have a perfect consent for every orthopedic procedure, and we will have a sort of you can say as a guideline also, and everything we know included into that. Just Dr. V.N.Deshpande said that what are the multiple options which are available, and patient has chosen this, and then what are the pros and cons of that particular procedure which the patient has chosen, and I'm working on that, and we will have a nationwide accepted by IOA or approved by IOA consent format all over India.
Thank you, sir. Thank you,
Very
Dr.
nice. Very nice.
Can I add to this?
I think.
Yeah.
Those who are interested again to write another chapter also, because we are now 27 chapter, we are going to increase up to 30 to 35 chapter on a different outlook. And if those who are not present in this webinar also, they can also contribute. So there is no issue, and probably we'll have a very good book of 150 pages, and at least 5 pages are given to a one author. And probably I am looking for a very good sponsor for this publication, so that all EMO member will get a free 1 copy. And if they want to buy for their staff, they will get another one with a very minimum price. So don't worry, Prakash Babu, Sanjeev Babu, everything will be sorted out. और हमारे treasurer सामने खड़े हुए, he will accept everything. Thank you very much.
Thank you.
I have some comments.
Okay, sir.
See, we are publishing. We have published already, for example, fracture neck femur booklet in Marathi, so that it will give you the information of all the aspects of fracture neck femur. And such booklets are in Marathi we have published, and we give it to the patient before taking a consent. That is number 1. Second comment is, Dr. Gadegone, we have now talked only on orthopedic OTs, but there are so many things. You have to write about infection control regarding the patient himself as a cause, then wards as a cause, then post-operative care is also an important aspect of infection control. So we have to if the booklet is there, should be a control of surgical site infection, and do not name it as a temple. My temple of OT is my temple, because OT forms only a major part of this, but there are other aspects of surgical site infection.
Your point is well taken, but actually we are working on the booklet because it is not going to be a very book. Only we are concentrating for the first time in operation theater. Then probably we will for a ward and something like that. So in my tenureship and Karne's tenureship,
you should include these wards and other things.
Okay. We'll आपको ही लिखना पड़ेगा.
Dr. Kulkarni sir, you can send those all whatever. Dr. Kulkarni sir, you can send whatever you have written to the MO office, and we will definitely try to include all your experience and whatever you have written about neck femur or any other orthopedic conditions, and we will assure you that it will be included, and it will be for the benefit of everybody.
Okay. Sir.
Manoj,
So
any
thank you
questions
very
on
much.
YouTube?
Okay, thank you, sir.
On
Thank you. Bye-bye.
13 तारखेला भेटू. मी नाही आहे त्या दिवशी, परंतु डॉक्टर गवाले and डॉक्टर पहुकर and everybody will take care of you. करने सर तो है. ठीक है सर.
क्या सर आप वाघ देखने को जा रहे हैं क्या? टाइगर देखने को जा रहे हैं क्या?
नहीं, मैं जा रहा हूँ आगरा को लाइव सर्जरी प्रोग्राम.
Dr. Pahukar, will you conclude the webinar now?
तुम्हालाच कन्क्लूड करायचं आहे. तुम्हालाच करायचं आहे.
अरे कन्क्लूड
तुम्हालाच करायचं आहे. हा तुम्हालाच करायचं आहे. As a moderator, you have to conclude.
Okay. So friends, we had a very informative and interesting webinar, starting from the OT setup to checklist. All the important aspects were discussed threadbare, and I sincerely thank all the orthopedic surgeons as well as the invited guests and the invited faculty from AIMS, Dr. Agarwal, for very valuable inputs. At the end, I thank all the people who have watched this webinar, and most important, I thank Dr. Gadegone for initiating this project. Thank you all.
Thank you all. Yeah.
Thank
So,
you.
Dr. Agarwal.
I think we can.
Alok, sir.
Dr. Alok Agarwal, I would request you to give your inputs and suggestions about how we can improve this in future.
I think he has
stopped.
Only left.
Are Dr. Agashe, sir.
Yes, please.
Hello.
बोलो किरण.
अरे नहीं वही बोलना था कि हॉरिजॉन्टल ऑटोक्लेव इज मस्ट. नो टू वर्टिकल. वो भी बिल्कुल स्ट्रिक्टली बोलना चाहिए फॉर ऑर्थोपेडिक सर्जन.
हाँ ठीक है.
Okay, Dr. Neeraj,
Okay,
if
bye.
you can, Neeraj, if you
Bye,
can.
everybody. Yeah, bye.
Yeah, can we leave the meeting now?
Okay, sir.
Thank you, sir.
Thank you, everybody.
Thank you, sir.
Thank you.
Thank you.